Good afternoon. Today is September 6th, 2023, and it is 3:02 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Texas Strategic Planning Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. The first item of business is public communications. Members of the public who wish to make comments virtually during the public communications portion of the meeting must have registered with Central Health via the online form or by telephone no later than 1:30 p.m. today. Yesenia, did anyone register to make comments for the Strategic Planning Committee meeting?
Yes, we have 4 individuals signed up to speak for public communication.
Okay, so we will start with the individuals. So I'm ready to take the comments.
Okay, perfect. I will now read the guidelines for this meeting's public communication. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction, and please indicate which meeting you are here to speak on. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let the speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion at a future meeting. We received 4 submissions for public comment. At this time, I will call on our first speaker today, who's here in person, Laura Elmore.
Good afternoon. Thank you for coming.
Hi.
Yes.
Good afternoon.
Yes.
Thank you, Dr. Bell and Central Health Board of Managers. My name is Laura Elmore. I'm the CEO of the Sobering Center here in Austin, Travis County. And what we do, in case you don't know, is we provide safe sobering services as well as connection to treatment for individuals who are publicly intoxicated. So what we are doing, what we have been doing primarily, and when I started there, was taking referrals directly from APD and EMS who were publicly intoxicated, sobering them up, and then doing an assessment and trying to connect them to care. When I started at the Sobering Center in 2020, the Sobering Center is only 5 years old. We just are about to celebrate our 5-year anniversary. When I came on 3 years ago, we started adding a couple of things. One is that we decided that APD and EMS and sirens were not the only way to get access to the Sobering Center. So we wanted to add referral partners. So we added 65 referral partners in the past 3 years. So now places like Community Care, Integral Care, Safe Alliance, all kinds of different community orgs can refer to us, including Capital Metro, the university, so that anybody who is publicly intoxicated or someone's concerned about, we can take care of them with our staff of paramedics and social workers and connect them to care. The other thing that we started doing in 2020 was holding patients a little bit longer. When we started, we were just holding people about 6 to 8 hours. We would admit them, sober them up safely, hydrate them, and then send them back out. But what we know about folks who are struggling with serious addiction issues, which is a pretty large percentage of our population, once they're ready to go to treatment, and oftentimes that requires medical detox, that is not an available resource in our community. So we end up having to hold people at the Sobering Center for up to 5 days, sometimes longer, just to get them sometimes on a bus out of Austin, Travis County, because we do not have residential substance abuse treatment resources here. So we started holding patients over, and we ended up having great outcomes with that, because if a patient decides they want to stay and go to treatment, we're able to get about 95% of them into a warm handoff. Who we're serving is all of Austin and Travis County. About 70% of our patients are one-time visitors, so that's going to be what you think it is: downtown partying, tourists, students. About 30% of our patients are homeless. I would gather probably at least 30 to 50% of our patients are your patients, our Central Health patients. There's our agency was formed through an interlocal agreement between the city council and the commissioners court. Our board, like your board, is appointed by the council and the commissioners. Our board chair, Jana Ortega, is here in the audience. We are funded currently by the city of Austin, by Austin Public Health. That interlocal agreement is about to expire at the end of September, and we have been challenged directly, informally, and formally in public city council meetings to find a different revenue stream. Specifically, why isn't Central Health paying for this? So that is a great question. For the past 3 years, I've been at the Sobering Center. For 4 years before that, I was the CEO of Austin Recovery, and we had similar conversations with Central Health over the past 7 years. I think that we've run into two major problems. One is that sometimes we're told that substance use is not the wheelhouse of Central Health. Other times what we're told is Central Health can't pay for this because it's already being paid for by the city.
30 seconds.
So we're a little bit stuck in a trap here, and we're working with the staff, but we've kind of come into a jam here. So what I'm asking from a governance perspective is for you all to look into the budget in terms of what are the investments for substance use care. Does MAP cover treatment? And would you be willing to make an investment in the Sobering Center to keep us going? Our overall budget is only $2.5 million, so it's actually pretty small potatoes. Thank you for listening, and I appreciate your consideration.
Can I ask a question? Yes. And so, can you tell me, do you have any idea how successful you are?
Define success.
That somebody actually doesn't return, like within the next 6 months to a year.
So we don't measure success by returning because what we're trying to do is divert from the jail and the hospital. So what we are doing is meeting and exceeding our goals for diversion. So we're saving the county and the city dollars by diverting from jail and the hospital.
Right.
What we hope to do is connect people to long-term care if it's an option, but oftentimes it isn't an option. And then once they're in long-term care, we don't really have a way to track them,
right.
Because we're really just a public service. So think of us like the emergency room for substance use. So if someone has a heart attack and they go to the emergency room, we often don't know if they continue eating bacon.
Right.
Because we just do what it does to take care of them right in the moment. Yeah. So we're really a crisis stabilization facility. We do know that our warm handoff to treatment rate is 95%, but that is like a funnel of the intakes and then the people who agree to stay long enough to be patient enough to get into long-term care, and sometimes that's out of town. So if we could get a release and they would be willing to tell us how they are, we could track those outcomes. But we see actually our repeat clients as success because they keep coming back to us and not to jail or the hospital, which ends up being cheaper for the community, but also a little bit healthier for them in terms of trauma, collateral consequences, medical bills, citations, criminal background, and all of that. So we ended up developing a relationship sometimes with people who are chronically sick and are rotating in and out of systems anyway. A lot of times we can get into treatment, sometimes we can't. But we actually see a repeat visit as a success as long as we can engage the patient.
Right. Thank you so much.
Thank you.
Manager Kitchen.
Can I just ask that we have an agenda item? I don't know which committee it's appropriate for, but I'd love to have an agenda item to have a further discussion with you. Perhaps she could come and present and have more time and we could have a discussion. I'll leave it to you all to decide which committee. I'm looking at both of y'all. I don't know which committee it's most appropriate for.
Yeah. Budget and Finance.
Budget and Finance.
Okay.
We'll do it.
Chair, would that be acceptable to you? Okay, thank you.
Thank you so much. Thank you.
Thank you.
Yes. Oh, I'm sorry. Manager Jones.
Thanks for presenting. Can you speak to why Austin Public Health indicated that you should find another funding stream?
Yes. So their position on this is that this is a healthcare service and therefore they should not be paying for it, that Central Health should be paying for it. What is tricky about all of that is that it hasn't historically ever been paid for by Central Health. We don't have a contract with Central Health. It's not billable to insurance or Medicaid or any other revenue streams. So we're kind of trapped here. Austin Public Health is often saying this is not a public health issue, this is a public safety issue. So I think they have also considered moving us over with APD and EMS. But it's kind of up in the air right now. And so they are not going to drop us in hot grease, as they have said. They're not going to just quit funding us, but they do want us to diversify our revenue, and we're kind of stuck there. without additional revenue streams.
Okay, just caveat. I was director at APH.
I know.
When the concept came forward, so that's different from what I recall. So thanks for enlightening me. The second thing is that there is now a public health commission.
Yes.
And I would encourage you all to present before them in terms of getting more support from the city, because I do think this is a public health issue. It has
I
other
agree.
components, but
I was scheduled to present today, and they canceled the meeting. I'm not sure why, but
Oh, okay.
that's on my radar as well. The city did agree in this interlocal agreement to pay the operating expenses of the Sobering Center for 5 years. That's expiring. And so what they're saying now is you need to go diversify that revenue, but there's not a lot of other revenue streams for it. And when I say substance use is a healthcare issue, any brain issue is a healthcare issue, it affects every organ and tissue of your body, they say, that sounds like healthcare, go talk to Central Health. So I'm a little bit stuck in a city council meeting when that happens, just trying to pay the bills.
Thank you. Manager Martin.
Thank you, and thanks for the work. So, as Manager Jones was alluding to, this sounds more like just a public safety issue. It's public health because they get sick. Are there physicians present at this center?
So we share medical direction with EMS, so they're on call. They're not physically present.
Okay. So if they're taken to the jail, or the alternative, if they're, first off, I imagine they're brought in by police officers for public.
Sometimes they are brought in by police officers, but also by EMS and also by the emergency rooms and also by about 65 other community entities
But if y'all were not available, they'd be in the emergency room
or the jail,
or the jail.
depending on the referral partner.
So the service would then, the expense would then shift to them again,
Correct.
which is actually, the hospital gets funds for this, the city doesn't, so.
Right. And we're actually saving the hospitals more money than we're saving anyone else. They're not putting in any funds into it either.
And that's my point. I think that should be argued with them.
Right. And I did talk to them, and they're saying we're probably not going to do that because it's actually not going to end up saving bottom line dollars. So you should talk to Central Health.
Thank you.
Just trying to be transparent.
I appreciate it. Thank you.
Yes, Manager Valdez.
As we all agree with, this is symptomatic of mental health or an addiction or something that needs our care, whether we have the mental health component like integral care used to, MHMR, mental health, behavioral health, physical health, medical health, it's all under the roof of Central Health and healthcare. So thank you for coming and bringing this issue, which is one that needs to be addressed by us and by the other entities in our enterprise and by the other agencies that we fund, so that we can all work together in tandem and no longer be passing the buck as opposed to accepting responsibility for the deaths that are occurring. Thank you.
Thank you. And I'm happy to do a more in-depth presentation if that's helpful, with more data and cost-benefit information and all of that.
Yes, Manager Musaitif.
Yes, thank you. So I welcome that to our committee. So we'll have staff coordinate it. So,
Okay.
thank you.
Wonderful. Thank you so much.
Thank you very, very much, Ms. Elmore.
Thank you, Ms. Elmore. Up next, we have Jeronimo Rodriguez, who's joining us online.
Good afternoon, Chair and members of the Central Health Board of Managers. My name is Jeronimo Rodriguez. I serve as the Chief Advocacy Officer for Ascension, Texas. And I'm here in support of item 1 of the regular agenda, the amended mandatory payment rate under the Local Provider Participation Fund of 6%. Just wanted to also share that as we provide health care for our community, we are now providing up to $564 million in charity care a year. And the Local Provider Participation Fund helps us continue to be sustainable and provide health care in our community. And so just wanted to add our name in support of the Local Provider Participation Fund rate. Thank you.
Thank you. Any questions? Thank you so much.
Thank you.
Thank you, Jeronimo. Up next, we have Justin Flores, who is joining us online.
Good afternoon, and appreciate everyone's time here. My name is Justin Flores, and I work on behalf of or some of the local hospitals there in Travis County, Ascension, like Geronimo just mentioned, Baylor Scott and White, and UHS. And we also wanted to, on behalf of our clients, be in favor of this amended 6% rate that was just mentioned. This is integral to ensure that patients continue to receive quality care, and we just wanted to voice support for that on behalf of our clients.
Thank you, Mr. Flores. Manager Masaitov.
Well, thank you, Mr. Flores. I have a quick question. The hospitals that you represent are Ascension CN, Baylor Scott and White, and the third one, I'm sorry, I didn't catch it.
UHS, so Austin Lakes and Austin Oaks, and actually I think Austin Lakes just closed not too long ago, and also Texas Neuro Rehab.
Okay, thank you.
Thank you, sir. And thank you for appearing. Thank you.
Thank you very much. And finally, we have Corey Clark, who is joining us online.
Hello. I'm sorry. Are y'all able to hear me?
Yes, sir.
I'm speaking remotely. Okay. Well, thank you. Well, my name is Corey Clark. I am an LPC, a licensed professional counselor who works at Integral Care. The reason I wanted to speak today was because of a recent communication that went out from Mayor Kirk Watson's office. It was in regards to the budget shortfall at Integral Care that you may have heard about. I wanted to call in and say that I was very appreciative of Mayor Watson's support for this policy of trying to get some.
Mr. Clark, Mr. Clark, can you speak up just a little bit more?
Oh, I'm sorry. I apologize. I'm on a headset. I had to. I apologize. If you're unable to hear me, I'll just make the comments brief. I simply wanted to draw the board's attention to the proposal to provide some potential support to Integral Care and say that we were very appreciative of that, or I myself am very appreciative of the community support there. So thank you.
Thank you so much. Thank you.
Thank you. Thank you. And we could actually hear online. So in case the managers needed to listen back,
Okay.
We have the recording as well.
Thank you so much.
Thank you. And this
Thank you,
concludes the public communication portion for all of the meetings, the Strategic Planning Committee meeting, Budget and Finance Committee meeting, Executive Committee meeting, and Board of Managers meeting.
Great. Thank you so much, Yesenia. Okay, so thank you for everyone for their comments, and we will now proceed to the committee agenda. Item number 1, review and approve the minutes of the August 9th, 2023 Strategic Planning Committee meeting. Do I have a motion? Yes, Manager Vasquez and Manager Kitchen seconds. Number 2, vote, please. Oh, yes, I'm sorry. Would everybody vote?
Aye.
Aye. Okay. Number 2, receive and discuss an update on community engagement and outreach regarding FY 2024 budget and strategic priorities. Ted Burton, Yesenia Ramos, and Christian Nelson will be presenting with the backup, if needed, of Ivan Davila.
Thank you, Chair Brinson. Good afternoon, board members. My name is Ted Burton. I am Yesenia is wearing 2 hats here today. I am Chief Communications Officer here at Central Health, and we are here today to share with you our 2023 Community Engagement and Outreach update regarding our FY FY24 budget and strategic priorities, our healthcare equity plan, and our CEO search community engagement. With me today is Jacinda Ramos, who is our community engagement supervisor, and to my immediate right is Christian Nelson, who is our project manager for communications and community engagement. And joining us remotely is Yvonne Davila, our Senior Director of Marketing and Communications. I see him there. He'll be here to also answer questions as well. As we have in the past, today we want to share with you a recap of our outreach efforts to reach our patient population, people who are up to 200% of the federal poverty level, some of whom are enrolled in MAP and others who are not. The communication team works very closely with our data and strategy teams to identify areas in our community with the highest concentrations of people 200% of the federal poverty level or below. You'll also hear tonight about our intentional efforts to reach communities of color, people who speak languages other than English and Spanish, people who may or may not have access to the internet or have limited access to the internet. However, our engagement efforts for our budget and strategic priorities for next year are not limited just to our patient population. Regarding our budget and strategic priorities, we really try to reach all of Travis County, everyone in the community who pays taxes and helps support Central Health. Next slide. So back one, please. Our community engagement goals. We want to educate members of the public about Central Health's functions, how we pay for medical services, our healthcare equity plan, and as I mentioned, our budget priorities for FY23. This is a 23 report. And then second, we want to gather community input on strategic initiatives that can help us shape our work and really meet the needs and the direction of the public. Next slide. And with that, I will turn it over to Christian.
All right. Good evening, everyone. Sorry, I had to stand in solidarity with Ted there. Good afternoon. Again, my name is Christian Nelson, and I'm here to give an overview of our community engagement tactics throughout the last fiscal year, beginning with Community Health Champions. So, as many of you know, Community Health Champions is an annual health equity ambassador program that Central Health runs, where over a 5-month series of workshops, which includes a health equity training that provides more context to our work and our patient population, participants of the program learn about all aspects of the Central Health system. So this includes who we are, why we exist, who we support, our partnerships with Community Care and Sendero, as well as even a workshop focused around this engagement report to really show them exactly the scope of our work and how we're getting involved in the community and how we utilize that community feedback. So we're continually streamlining the information from this to make it more digestible. However, it's still fairly dense given the scope of the information that we're covering. And as such, it's a competitive application process. So the average class size is around 35 participants per year. For example, this year's current cohort has 38 participants out of a record 117 applications. Since the program began in 2016, nearly 350 health champions have completed the program and joined our alumni network. Now, new this year, something very exciting for us. As I mentioned, the Health Champions program is very competitive, and it's primarily tailored to suit healthcare, government, and social service professionals, just given the scope and the depth of what we're covering. So when we were reviewing the applications for the 2022 program, we realized that we were missing something with a lot of the applications that scored very lowly. And what we recognized is that we were missing a really significant opportunity to reach community advocates from our patient population. And so, I'm proud to mention that this past March, we launched the Accelerated Community Health Champions program. So, this is a 1-month pilot that we did. So, it's a 1-month accelerated workshop series. This one was entirely in Spanish that we did for the residents of the Runberg and St. John's communities. What we aim to do with this is provide a targeted, accessible approach to healthcare advocacy for populations in high utilization MAP service areas. We focused on recruiting participants with lived experience in social health disparities, including those with limited income, education, access to transportation, and language and literacy barriers, hence why we did a full Spanish program, and I don't speak Spanish. It worked out very well, though. Notable differences between these programs is that this program is designed to focus on local neighborhoods, specific resources, services, and advocacy, versus the more macro level approach to the General Health Champions program. We have a limited class size. We try to keep it small in scope in a more intimate setting between around 10 to 20 people. Also, we accept all applications. So anybody who applies for this program will be accepted. They will get accommodated. We'll do whatever we need to do to make this work for them. If we do end up having a ton of applications, we would split it into smaller class sizes and handle it that way. And again, one of the most significant aspects of this program is that it's designed to easily adapt to any language that we support. So again, we did this first one entirely in Spanish. We could replicate that in any other language as part of our language access initiatives, and we may well do that next year. So the goal is to conduct accelerated programs in 2 to 3 communities each spring, based on need, interest, and how well those areas align with Central Health's ongoing initiatives. Where we chose these this first set from was based around our 2022 engagement report and where we identified key focus areas, so we decided to start there. And as I mentioned, with our alumni, Health Champions alumni, they're one of our most invaluable resources as ambassadors. They tend to be our most active and well-informed advocates, and they play a crucial part in amplifying our mission in the community, notably, through helping us develop and implement new community initiatives, such as a Meetings in a Box initiative that we outrolled, which is community presentations, mobile presentations essentially, which we can take out to any community location and do. Strategize and refine our community outreach and engagement efforts, as well as provide volunteer support. So they really cover all the bases for us, and they've been integral in developing the processes that we have, including Meetings in a Box, and how we continue to evolve the Health Champions program. So in addition to that, we have community conversations, in which Central Health hosts public meetings to keep the community at large informed on what we're doing at a given time. We hold these community conversations in areas with highest concentrations of families living in poverty, again, per the 2022 demographic report. As you see, this is a very important place to inform the work that we're doing and where we're doing it. And then we focus our Meetings in a Box efforts, again, on the remaining areas from that same demographic report. And it's important to note that staff ensures that accommodations for interpretation services and additional languages, as well as transportation support, is offered for these meetings as well. We also offer listening sessions where we look for opportunities to join established neighborhood community meetings throughout Travis County and spread awareness on the work of Central Health. And we do our best to tailor those meetings to that local community. So for example, if we're going to have an accelerated Health Champions program available soon in that area, we would mention it at that meeting, whereas we may not in another community where we wouldn't be hosting that. These sessions are conducted entirely by Central Health staff, whereas the Meetings in a Box mobile presentations are primarily conducted by our Community Health Champions alumni. And finally, we have intercept interviews and surveys. So we use these to capture feedback from individuals who aren't able to come out to our community conversations. We administer online surveys, over-the-phone interviews with a representative sample of both MAP and MAC Basic members, and in-person interviews in places where our target population gathers, so clinics, enrollment offices, schools, faith-based centers, events, what have you. It's important to note that these are not the only opportunities that we have for community engagement. These are just the highlights. And up next, Yesenia will be covering what the rest of those, or more in depth of what those engagement opportunities have looked like over the last fiscal year. Thank you.
Thank you, Christian. Next slide, please. So over here, we're going to be talking about our communications and our community engagement team efforts throughout this entire fiscal year. We've had several events. I know we've seen many of you from the board there, so thank you so much for joining us at those. First, I want to talk about the Healthcare Equity Implementation Plan. We, since the Healthcare Equity Plan was adopted in February 2022, we've continued to engage and inform the community about the current and future projects that will be happening in the next 7 to 10 years. In May 2023, our outreach team called 34 individuals whose primary languages were English, Arabic, Vietnamese, and Nepalese to gauge their experience as they used our services being MAP or MAP Basic members. You can view the member experience questions asked by our team members in Exhibit B in the engagement report that we've provided and on page 30. And the key takeaways from the results of those surveys on page 15 of that engagement report. We also hosted community conversations at the ACC Eastview campus, and we titled this community conversation, Healthcare is Getting Better, to share our healthcare equity implementation plan with our community. We offered interpretation services in Spanish and ASL, and the full conversation was streamed through Facebook Live. We had a record of 117 people RSVP with 80 people in attendance. And the event also featured a HAM, Healthcare Alliance for Austin Musicians, sponsored musician Kelsey Creek. So that was a great start to our community conversation that day. As of August 31st, the Facebook Live video had 394 views. You can find the key takeaways from that community conversation on page 17 of the engagement report. And our Eastern Travis County, so up in the slides we have our Hornsby Bend and Del Valley Health and Wellness Centers. Our Eastern Travis County engagement efforts have been very active since these grand openings will be in the near future. Central Health staff administered a survey in both of these areas to capture feedback from individuals about their preferred hours of operation for health education and wellness programs. Our engagement outreach and our wellness initiatives teams partnered up with Del Valley ISD to conduct these surveys at Del Valley ISD school pickup hours, which we found to be very, very effective. So our teams went out during school pickup as they're waiting for their students to get out of school. We asked them if they could please take a survey, and we received a total of 159 surveys for the Del Valley Health and Wellness Center and 262 completed surveys for the Hornsby Bend Health and Wellness Center. We also had help from our outreach partner, Community Coalition for Health, or also known as C2H, who helped us administer surveys at local businesses and Del Valley ISD resource fairs. Lastly, an online version of these two surveys were shared on Facebook and Instagram. You can find the key takeaways for these on page 18 and 19 of the engagement report. And I don't have my glasses. Okay, language access assessment. I'm really excited about this one. In early 2023, Central Health contracted with BCT partners to conduct an extensive assessment of our language access systems, policies, and practices as we step into the direct practice of medicine. Our team assisted BCT partners by coordinating 9 Central Health staff focus groups, online individual interviews with members of our senior leadership teams, and 5 in-person focus groups with MAP and MAP Basic members whose primary languages were not English. Our team recruited, and those languages were Spanish, Arabic, Burmese, Vietnamese, and ASL. Our team recruited these members by utilizing our current language access line and our current language access provider. They picked up the phone, dialed into our language access line, and asked for that language, and then we called our members with their respective language. We also helped link BCT partners with the account manager and the director of quality assurance at Language Service Associates, our current language provider, so that they could conduct an interview with them about our current language services. And lastly, an interview with program staff at Caritas of Austin and World Relief regarding refugee groups in the pipeline for future resettlement to Travis County. A total of 100 people participated in this project. BCT has developed and shared a report with staff that includes recommendations for Central Health to enhance its language access practices, while Central Health is already investing in patient support services as early as 2024 per our healthcare equity action plan. And next slide, please. And so Central Health held a community conversation in late March to share with partners and community members findings from our 2022 demographic report. We held that here in this room. We focused on inviting the public at large, elected officials, their staff, partners, and also our community health champions. This event was streamed here on Facebook Live, and you can find all the key takeaways from that presentation on page 22 of the engagement report. Our 2024 budget engagement efforts happened from August 10th and are happening throughout September 20th of this fiscal year. We executed several community engagement tactics to inform and gather feedback from community members about our 2024 budget proposal. This included holding 3 community conversations where staff addressed questions and comments throughout these events. One was held in person at the Southeast Health and Wellness Center. We streamed that one through Facebook Live, and we offered interpretation services in Spanish and ASL at that one. The other 2 community conversations were held at the Asian American Resource Center in Northeast Austin. That one offered Arabic, Burmese, Spanish, and Vietnamese interpretation, and the Travis County Community Center at Pflugerville, which we offered Spanish interpretation. And this was all based on needs as we called to do our outreach efforts to invite our patients to these events. Participants received information about and discussed the proposed 2024 budget and how the budget is helping to ensure healthcare is getting better in Travis County by filling the gaps as identified in Central Health's Healthcare Equity Plan. And on October 10th, staff kicked off the 2023 Community Health Champions cohort with a workshop. As Christian mentioned before, during this workshop, health champions became familiar with the Central Health system, including community care health centers and Sendero health plans. And like Christian also mentioned previously, our staff joins and participates in community meetings where we share information about Central Health and we receive feedback from community members. Our community health champions have been taking these meetings in a box presentations out to community members to ensure that we're reaching the focus areas with the highest concentrations of people living in poverty. And as you all recall, last week of the 10 people who signed up to speak at our public hearing, 8 individuals spoke at our 2024 budget hearing. 6 people came in person and then 2 people came online. Our CEO search continues. As reported in yesterday's ad hoc committee meeting, we received a total of 225 completed surveys, and we were asked to conduct 20 more Spanish surveys, of which, as of maybe a few minutes ago, we have 15 completed. So we plan to get 5 more for y'all, so we will report back. And next steps, we're conducting intercept interviews at the Southeast Health and Wellness Center and the Northeast Health Resource Center to increase the number of surveys in Spanish. So that's where those surveys came from. For our next slide. I believe this one's Ted.
Yep.
Pass it on
Thanks,
to you, Ted.
Yesenia.
Thank you.
So, as you've heard, we do use a comprehensive approach to reach our patient population, non-patients, prospective patients, and the community at large. You can see some of the marketing and outreach tactics here, but it really is from shoes or boots or sandals on the ground, one-on-one interaction, to covering the airwaves with paid advertising when it's appropriate, but also reaching people on their mobile devices, the devices that they have with them almost every minute of the day. And on page 13 of the report, you can see some of the communication tactics that we're using, but everything from newsletter and email correspondence. We have about 7,000 people who've opted in to receive our emails. And so we communicate with them about important updates. For example, when there are community conversations, public hearings for the budget, everything that we do is always in English and Spanish. when it comes to our newsletters and emails. We send out a bi-weekly email to our community partners and advocacy groups. About 600 people who are even closer and have opted in for that more repetitive communication or more immediate communication. Social media, if you follow us, you know we're very active on social media, Facebook, Instagram, Reels, Twitter, or X. So we use all of the social media platforms at our disposal. And when it comes to community outreach, it's not just in-person outreach, the things that Yesenia and Christian mentioned, but we're also members of about 120 Facebook groups. So meeting people where they're already having conversations and trying to insert ourselves in appropriate ways in those conversations. And then finally, phone calls. So Yesenia mentioned many of the different issues that we've worked on, but picking up the phone and calling MAP and MAP Basic members, folks who may not be connected to the internet, speak languages other than English. So calling them and doing surveys and asking questions and inviting them to come participate in things like our community conversations. Our staff, as Yesenia mentioned, our outreach specialists are at 2 different clinics today conducting the CEO search surveys in Spanish, but they were also out there inviting people to come to our community conversations. So we try to stay as engaged as possible one-on-one with our patient population. And then I mentioned advertising and then media relations. Mike Clark-Madison, probably tweeting as we speak, is in the audience. Mike has been with us for about 5 or 6 months, came to us from the Austin Chronicle. So we really try to stay connected to local media, making sure that we're answering their questions and giving them clear, concise, fact-based information about what we do and how we do it. Next couple of slides are just a couple of examples of hopefully some of the creative that you may have seen. So examples of online advertising, flyers, posters. Go back one, please. This one is in regards to one of our community conversations back in July. And then the next slide is another example of one of our budget community conversations. Actually, this one, the flyer below, has all 3 of the budget community conversations for people to know where they are, when they are, and how to RSVP. Next slide. Yes,
And on this page, we have our participant breakdown for our engagement participants this year. Our overarching community engagement goals include educating MAP members, MAP and MAP Basic members, and the public about Central Health's functions, how the district pays for medical services, and the healthcare equity plan, and our budget priorities for fiscal year 2024. Gathering public input on the way we do our work helps shape our strategic direction as well as our budget priorities. And so we engaged a total of 1,014 participants this fiscal year, which is a 61% increase compared to the 630% last fiscal year. And next slide, please. And this is just a breakdown of our participants by zip codes. As you can see, it is darker in the eastern Travis County areas because we are building 2 new health and wellness centers there. So we have been engaging those 2 locations just a little bit more. It doesn't mean that we haven't been engaging in our other focus areas. It's just the area that has received more participation this fiscal year. And next slide, please.
And finally, this is the team that I love to brag on. I'm fortunate to work with so many passionate, smart people who are out in the community, connecting people to care and coverage, and just really care about the work that we do in the mission of Central Health. You've heard me use the phrase, the dream team. So this is the Central Health Communications and Community Engagement team, or as we've all come to use the term, I hope, the dream team. I think with that, I believe that's all of the presentation, and we welcome your questions and comments.
Managers, does anyone have any questions? Yes, Manager Besite.
Well, I don't have a comment. I have a thank you and appreciation for all the work and outreach that you have done over the years, and it's growing. And I really, I remember I was one of the product of the community health champions with the first inception, seeing it how it grew. It bloomed like it's an incredible program, and how it has evolved and really engaged many individuals within our community. I'm happy also to learn about your other program that you really came out of as a gap and need, that really mainly focuses on more precise patients. And that, thank you, and I applaud you for all your work that you have done thus far. So thanks, and continue on the hard work. Thank you.
Thank you. And Manager Kitchen?
Thank you. I just have a quick question as a reminder, really. I'm trying to remember how large the Community Champions group is, and I assume it's a certain number of people in a class every year, and that contributes to the whole pool. Is that how it works?
Yeah. Go ahead. Yeah, so right now we're at approximately 350 lifetime members since 2016. About 254 are still actively engaged, and that just happens naturally through, of course, COVID. As people have moved on to new jobs, you have dead email addresses, things like that. So we're doing what we can to bring back old members who have been around for a long time. Some of our most engaged members are from those earlier classes. Some of our most engaged members are on our board, including Amit, who's not here today, unfortunately. We early on had a larger class size. I believe they were 50 plus. And feedback from those classes were they were just too big. So they didn't have a good enough opportunity to engage with each other and to give their feedback. And really, because we're limited to 2.5 hours for these classes. So we need to be able to accommodate them as best as possible. So now we generally try to keep it between 30 and 40, depending on the class size, knowing that we might have a few people drop off over time. So we end up around 35 each year is our ideal.
Okay, and so what kind of activities do you do to help people stay engaged?
Well, as I mentioned, our alumni are probably the most involved when we have volunteer opportunities. They help us with, we have an alumni engagement committee, so they help us with event planning, mostly around Health Champions. They help us with, again, coming up with new initiatives. Our Meetings in a Box initiative was developed in joint participation and collaboration with them. This year, we're bringing back the concept of class project. So instead of waiting until they graduate from the program and saying, congratulations, you made it, we'll let you know when we have something for you to do. We'd encourage you to come out and speak at Board of Managers meetings, at Travis County Commissioners Court. We're trying to get them onboarded as they're going through. So whether that's donation drives, coming out to our grand openings, coming out to speak at these meetings, everything that we encourage the community to do, we're encouraging them to do from day one. So we want to instill in them a passion for service as we're telling them who we are, what we're about, and as we go through the program and we get them excited, especially with the health equity training, and they're ready to go from day one, we don't want to miss that energy. We don't want to miss that opportunity. So we're getting them involved everywhere that we can.
Last question?
Yes.
Last question then is, help me understand the how many we're able to accommodate versus how many apply.
Each year, the application pool is a little different. We generally go from May to June for the application. So basically the month of May, and then early June is when we take the next step. We started a little earlier this year in mid-April. So our target goal is always 100 applications. And over the years, it's been scaling up and up and up. And whatever we did this year, we got well over 100.
Okay.
Which is it's a good problem to have. What's unfortunate is that we know we're going to have to cut a lot of really good people just for capacity. Again, this isn't even something that we would love to take everybody if we could.
Yeah.
Space is a concern, time is a concern, but again, it's the feedback directly from previous year's participants, and it's not just one class, it's numerous classes, that they want that smaller curated experience because that's what's going to help them become the best advocates that we can do.
Okay, so sounds like about double what capacity, or give or take. So, okay, thank you.
And if I can add, a lot of our health champions end up becoming part of the Central Healthcare Equity Policy Council, CHEP Council. So that's another way that our health champions get involved. It's kind of that first step before they join the CHEP Council.
Okay, thank you.
Thank you, Manager Kitchen and Manager Valadez.
Norma, thank you all for growing the health champions. Thank you all for growing the health champion component. When I first came on the board in 2015, this is the program that I advocated for. And the reason I took it was the idea from AISD had their up close program. The city of Austin had their program for teaching the community members how to become more involved in what exactly City of Austin had to offer. So when I came on board, I said, well, why isn't Central Health doing that? And so that's from where it came, the health champion idea. And one of the reasons that I wanted the program to exist and for the people to participate was that so they would go out and become our cheerleaders for Central Health, but more so that they would involve their communities and educate the communities about what Central Health had to offer. And it was always a disappointment to me that we didn't do what you're doing now, which is the non-English speaker or the smaller class for the bureaucrats or for the professionals who are already in the field, who are already working with all the entities, who are most engaged and most informed about what Central Health has to offer. I wanted us to target the people who didn't know what Central Health had to offer. And so I'm glad that you're doing that now. I appreciate the fact that you have targeted Runberg, because Runberg is a unique community in that it has had a lot of entities, including originally Latino Healthcare Forum, go out and organize in that community. But we also have Dove Springs. We also have Del Valle. We also have what's left of East Austin that hasn't been gentrified. And my hope is that you all will grow programs in those communities. Out southeast, they have a temple out there for the Asian population, which could participate. The same thing with northeast. And so I would hope that you would consider growing those at the same rate that you are investing in the regular English-speaking community health champion component. Thank you.
Thank you, Manager Valadez. Oh, Manager Jones.
Yes, I'd like to concur with my colleagues. I thank you for the great work you do. I just have a couple of specific questions, and you can provide them to us later. But do you go into community housing projects and conduct these types of recruitment efforts and education? And I don't mean in terms of parts, but like in particularly housing projects.
We haven't this fiscal year. I don't know if we did the previous fiscal year. I think Yvonne might have unmuted.
So we've been relying on, can y'all hear me okay?
Yes.
We've been relying on community C2H and other vendors for on the ground outreach, and our 2 community health workers as well. So for the voice of the community, I know that we did a lot of, we went to apartment complexes in areas with high concentrations of families living in poverty. And so I know for the voice of the community, we did that. This time around, we have been focusing on making phone calls directly to our MAP members to get them to come to our community conversations, where we also provide free transportation and a meal as well. So that's what we've been focusing on, is actually making phone calls to MAP members with limited English proficiency to get them to get involved. That's what we've been focusing on.
And we also have done outreach at multifamily housing. I can remember specifically in the Hornsby Bend area, but we can get back to you with a more detailed report on locations and activities.
Particularly, one of the concerns I have is, are we getting to the Booker T. Washington housing complex? Are we getting to the Thurman Heights complex? Are we getting to some of those, particularly where African Americans are in larger number, but they may not be in the neighborhoods of others? So I'd be interested in those numbers. I'm glad to see the C2H is I'm sorry. I'm glad to see that you're engaged in C2H. I'd be interested if there's a role for them to enhance or increase more of what they're doing in some of these other targeted projects. And then the second question relates to seniors. So are we doing a lot with engaging our senior populations in these areas in terms of the community conversations and the like? And for those, some of us who are seniors, we consider those are over 50, not just 65, but are we engaging those in terms of addressing and getting their feedback and their engagement?
Yeah, I don't have the demographic breakdown in front of me if it's in the report, forgive me, about some of the community conversations, but I think we could get back to you and maybe give you some better demographics. But I think even just anecdotally looking around the community conversations, I'm pretty certain I've seen one or two seniors at the community conversation. I'm not including myself in that category. But anyhow, I could get back to you with maybe some more specifics on the demographic breakdown for the community conversation and public events that we've held.
Okay, thanks very much. I appreciate that. And then the last question relates to the map that you've provided us with. I heard what you said, Yesenia. I think that this is just a picture of where your focus has been throughout, but over the last year, particularly in the southeast. Are you doing, are you not doing that at the expense of the northeast, some of the northeast, or the central east parts of Travis County, are we?
No, correct. So the light blue in that
Right.
map shows the areas where we've had participants. So that's not just showing Travis County as a whole, that's showing the
Right.
places that we have zip codes from the actual participants. It's not to the expense of, I think it's just we're doing more engagement as those two centers are coming up.
Coming online,
And
okay.
that's probably also why our engagement number is higher this year, 61% higher as opposed to last year.
Okay.
The surveys, the advertising, the on-the-ground outreach. So that's why you're going to see higher numbers around the Hornsby Bend and Del Valley clinics this year.
One last question. Does this include the zip code for the community of Webberville? Or do you know Webberville?
What is the zip code of Webberville?
I'm not sure, but
Straight out 969.
it's east of Hornsby Bend, and I'm wondering because that's an isolated.
Is it 78617? If not, we can get
I'm
back
not
to
sure
you. I don't know
the
the
zip
zip code.
But I would encourage you to do some significant outreach out in that area because it's a sort of not a colonial, but it's an area that is really isolated and has a large number of needs out there. So.
And we can get back to you. I believe our contractor C2H does do.
The Webberville area.
Yeah, they do the northeast
It's
part of Travis County.
it's the same zip code as Hornsby Bend, it's 78725. So they've been engaging with them quite a lot. So a lot of what you see on the map is a result of the surveys that we conducted for Hornsby Bend and Del Valley. So we got a lot of surveys completed in those communities. That's why you see the darker areas are 78725 and 78617, Del Valley and Hornsby Bend. And Webberville is part of that 78725 from what I'm seeing online.
Yes, but it's on the border between Bastrop County and Travis County. It's a little community out there. I would encourage us to do something because we don't want to leave them isolated as well. Thank you.
Thank you.
Thank you, Manager Jones. And you had one little comment.
One quick question. Thank you, Manager Jones, for your comments, because as he started out saying, that was one of the issues that we had, and that was exposing Central Health and their MAP services. We did not have MAP Basic at the time, to what was available to the population, to the uninsured. We were not dealing with any less than 200,000 uninsured in Travis County. We're still dealing with almost the same number, but more and more people are actually becoming exposed to and participating in our programs. But the issue is educating and informing those people, and it's very hard to do, as Shannon knows, as Manager Jones knows, unless you are a boot on the ground. You've got to do the door-to-door. You know, sending an email, sorry, it's probably not going to work. It may work west of 35, but it isn't going to necessarily work east of I-30. So that's
why we are using our comprehensive
That's
approach.
right.
We can't rely on one tactic alone.
No, that's exactly right. And so another reason for a class to be created out there, even if it's a small class, for people who are marginalized and not included in our targeted population. And one more thing, I also wanted to thank you again for reaching the non-English speaking population, but we need to do more because that's the majority of the people that we serve under MAP and in our population. So please look at that and grow those numbers if at all possible. And seniors, yes, you'll see a lot of seniors at the community conversations. But as to whether or not we're targeting them is a different matter. I think that what happens is people get used to the fact or think that Medicare is taking care of our seniors and Medicare is offering less and less every year, taking away services, not adding to that. And we do have a population that is not eligible for Medicare, that is within our MAP eligible population that we really need to target. Thank you.
Thank you. And we want to thank you very much for the presentation. It was great. Oh, yes. Oh, sorry, Manager.
I was listening and watching when I could, and am unsurprisingly echoing the gratitude from our colleagues around the room, and wanted to specifically enumerate just how over the years now I've been able to see this team grow and develop from a team that I already appreciated when I first joined to producing firm level products, I think, for the organization, whether it's the ability to manage audiences at a firm level or to be able to engage those audiences or to produce multiple tactics and strategies to be able to approach all the manifold audiences we're working with, whether they're patient stakeholders, potential stakeholders, taxpayer stakeholders, who all of us are. And I deeply appreciate it. Echoing also Manager Valadez's focus on appreciation of non-English speaking avenues of communication and engagement. I really appreciate that too. In fact, yesterday I think it was in a committee meeting. We had mentioned that we might like to see some more surveys in Spanish, and today I was listening in the presentation. It sounded like y'all turned those around, and that kind of stuff is just amazing to me. Not to mention, of course, that Community Health Champions program. Again, as Manager Valadez mentioned, there's the City Works Academy, there was the Austin ISD Up Close, there's our Health Champions program, and then there are pay-to-play programs out there around leadership too, right? And these programs, particularly this one that I got to participate in, is so profound in its engagement, but also what I'm hearing about your accelerator program, what a great way to make sure we just do it. There are so many reasons we can't do something. Oh, there's this barrier, there's that barrier. Y'all figured it out and just figured out a way to move forward, and I really appreciate that too. I don't see other organizations doing that at the rate that we are. There's always more to do, and I know y'all know that, and that's so comforting. Thanks.
Thank you. Thank you, Manager Matwani.
My colleague just informed me that we have 26 surveys, more Spanish surveys.
Oh my, amazing.
That our outreach team is.
Wow. Well, we appreciate all of your hard work.
I would like to, because there's been a lot of talk about the accelerated program, I wanted to thank Christian specifically and Yvonne for coming up with that idea, developing a pilot project and making it happen. So I do think we don't usually do things in 24 hours a meet, but we can. But I think that is one of the beauties of this team and this organization is the ability to be nimble and flexible and responsive and make things happen. So it's always a pleasure to report on the work that these guys are doing.
Thank you. Thank you so much. And there is no motion on this item. Okay. So I now announce that the committee is convening in closed session to discuss agenda items 3 and 4 under Texas Government Code 551071. I beg your pardon? Oh, I'm sorry. Okay. Let's see. So item number 3, receive an update on the central health dashboards associated with service level reporting for fiscal year 2023, and Sarita Clark Leach will be presenting in open session after the closed session portion. And number 4, receive and discuss a briefing regarding Travis County Healthcare District, DBA Central Health versus Ascension, Texas, FKA Seton Healthcare Family, cause number D1GN 2300398, and Monica Crowley will be presenting this item. Now, so you guys listen closely. Any questions? We want to keep it, as quick as possible, just because of Hello. It is September the 6th, 2023, and we are leaving closed session to open session, and the time is 5:38 p.m. All right, so we are going to receive an update on the Central Health dashboards associated with service level reporting for fiscal year 2023, and Sarita Clark-Leach will be presenting.
Good evening, managers. My name is Sarita Clark-Leach. I'm the Director of Analytics and Reporting here at Central Health, and I'm about to share with you healthcare utilization dashboards that show utilization in our primary care space as well as our hospital, Ascension Hospital setting. Next slide. Next slide. This first chart is one that you're somewhat familiar with. You've been presented with these data on a quarterly basis, disaggregated by quarters. And then on our website, you'll see it disaggregated on a monthly basis. These large green or navy blue bar, depending on how it renders on your screen, indicates the total number of visits in our primary care, urgent care, and convenient care settings for each fiscal year. And the lines on this chart, you'll see from the legend on the right of the chart, substratifies those visits by those specific service lines. So you'll note that in 2019, our enrollees had a little over 370,000 visits. However, there was a significant decrease in 20 and followed by 21. Notably because of non-emergent ambulatory care utilization, the impact COVID had on non-emergent ambulatory care utilization. In 2020, there were a little over 290 visits. In 21, about 291,000 visits. In 21, there were about 296,000, followed by a rebound in 22, up to about 327,000. And we expect that 23, which is shown as a partial year representing 3 quarters, should meet the 22 levels, hopefully surpassing them. Next slide. The next slide shows the graphic as it is on our website, and you'll note a link to the website below. The website also includes a geographical representation of utilization. There's a chloropleth map that will show you that utilization relative to where our enrollees live and in those areas where there are high concentrations of poverty. Next slide. Looking at our clinic demographics, the folks who traverse the clinic, when comparing race, ethnicity, it was interesting to note that folks who reported their race or ethnicity as other, and those usually are Native American, Pacific Islanders, and folks who either identify as multiracial or just other in general, tend to underutilize the clinic settings. And folks who identify as Asian, Black, Latino, or white actually utilize at a higher rate than you might expect given their enrollment proportions. When looking at age, our enrollees who are 45 or older tend to utilize the clinics at a higher rate than younger enrollees. And in terms of sex, folks who identify as males are underrepresented in the primary care setting when comparing their proportion among enrollees to the percentage of clinic visits utilized. And now we're moving on to our Ascension Specialty Care Clinic utilization visits. And looking at this chart, you'll notice that that 2013 is represented. 2013 is considered a baseline year to which we compare all subsequent years' utilization. And then we have the last 5 years of utilization going from 2019 to a partial year in 2023 that is inclusive of 3 quarters. And if I can bring your attention to the percent change since 2013 table under the encounters and patient counts, you'll notice that there is a significant decline in the number of visits and the number of patients served for each year after 2013. And this, I'm sorry, if we go back, the population represented here are folks, are MAP and charity patients, and MAP Basic is a subset of that charity population. And next. And here is a representation of our MAP population utilization of those specialty clinics. Moving on to our hospital utilization, we'll start with our outpatient services. And those outpatient services include testing, diagnostics, procedures, day surgery, etc. You'll note more pronounced decreases when comparing volumes in our more recent years to the 2013 baseline year. And again, this is our MAP and charity population, MAP Basic being a subset of that charity population. And moving on. And here's a representation of only our MAP population utilization. Again, looking at demographics for the population. Distribution doesn't seem to skew differently than our enrolled population for this population who received outpatient services, but it's a little hard to tell looking at the overall population because of the number of unreported race and ethnicity. Age-wise, the distribution of outpatient utilizers skews to 40 to 54-year-olds, and females are overrepresented in the hospital outpatient setting by 15 to 17% depending on the year. Moving on to ED department utilization. You'll note again, there's not a real discernible trend here other than to note the impact of COVID on 2020 and 2021. And this again is our all MAP and charity population. And then moving on to our MAP population. Again, no real discernible trend. There is a downward trend for encounters, but it's hard to tell how COVID impacted those numbers. Looking at our top 25 ED diagnostic groupings, you'll note that, so we're looking at the last year and then over the last 3 years, most ED presentations are related to abdominal or chest pain, musculoskeletal pain, and infections. These top 25 diagnosis groups account for about half of ED visits, and the top 10 account for about a third of ED visits. Next slide. Again, those looking at ED demographics, it does look like folks who identify as Black or white are overrepresented in the ED setting, but there is a large unreported cohort in the group, which complicates the comparison. In terms of age, the utilizers, ED utilizers are more in line with what we see with our enrolled population, skewing younger than 45, and distribution, sex distribution is about the same as the enrollee population. Moving on to our inpatient setting. Again, no real discernible trends here. We have the 2013 baseline year compared to the more recent 5 years of utilization. And this is looking at our MAP and charity populations combined. Next slide.
And then again, the breakout of our MAP population, seeing the same fluctuations. And these are the top 25 inpatient MSDRGs over the last year and then over the last 3 years. And again, you'll note that most patients were admitted with major infections, heart failure, diabetes, drug overdoses, metabolic, renal, liver, and other cardiac issues as their principal, as their DRG. The top 25 DRGs are associated with about 40% of all inpatient visits, while the top 10 represent about 30% of visits. Looking at our inpatient demographics, really the thing to note here is that males are overrepresented in the ED setting by about 5% or more, depending on the FY. And then unsurprisingly, folks who are older tend to be admitted more frequently.
Thank you so much. Any questions, managers? Manager Valadez?
Yes. Sarita, you know I love you. You're great presenter. I've loved you since community care had you. So I'm glad we had you. They never had me though.
We need the mic.
Oh, sorry. Okay, so I want to, maybe it's to Mike, Mike and Sarita together. I don't know if I'm misunderstanding something, and what I'm asking is, we have talked about how our encounters have increased at Central Health over the years. And when I see this, how is this reflective of an increase in encounters as opposed to a decrease in encounters? Maybe I'm misunderstanding something.
Yes, and so what you've seen tonight are specific breakdowns for MAP basic charity care with breakouts from MAP. Now, what we have shown you before are definitely increases in encounters, both historically as well as projected forward for 3 years for primary care. Now, that's a fairly expansive, and this was, and maybe a better way to say it is utilization by maybe type or facility, if you will, versus primary care encounters that occur across different types of facilities. But the primary care numbers also include dental, integrated mental behavioral health that occurs at the primary care level, and I would say alternative primary care visits as well.
Okay, maybe I'm missing something.
No, you're not missing it, because when you look at it just from the standpoint of, again, just looking at primary care, those numbers go up and have been going up, and we
because
project
that's
them
everybody.
too. But yes, but this breaks it down by specific place or type of utilization. But I don't know if there's a better way to articulate that.
So those
So I'm talking about
charts
for
that
our,
show those
I'm interested in our population. I'm glad that we're
Right.
serving everybody by having clinics, but with respect to our targeted population.
And our clinic volumes are increasing year over year, and that is usually what we share are those sourced from our claims data, as well as the work that's done at CUC to capture our population. So.
But I don't see utilization for the individual clinics. Is that a different comparison?
This is that first chart I showed with the bars and the lines are.
Is that a cumulative?
Yes.
Okay.
So
is there an easy way to disaggregate that per clinic?
Easy. If you ever see claims, what locations come through in claims, what they look like. So we have folks who have automated a process to identify those clinics, but there's always manual cleanup that has to happen. So it's not available on a dashboard per se, that breakdown, but we can produce it.
And this may not be necessarily anything that we would need to see in a public on a regular basis. But when I first joined the board, I asked to go sit in on a community care clinic, a board of directors meeting, because they're closed to the public. So I had to get permission to go sit in there and listen to the presentation being made. And in the presentation, they had a utilization report, which talked about what clinics, who they were seeing, and so if I wanted to know where utilization per clinic per specialty, and where does this patient live, so for them to be able to have to get to that place, because sometimes they're having to navigate all kinds of information to get there. That to me is important, not necessarily because I don't sit on the community care board, for how they're going to, for Jason to decide how the resources are going to be spent, but it's important for me just to have that as information for where are we serving our patients, who are they, what are they, and what do they need. And yes, I'm all about the Medicaid and Medicare also, because they have a place to go that they would prefer to go to than some other for-profit clinic. But that is important information. And I somehow sense that may be the information that we need to let the public know somehow or another. This is what we're doing. This is who we're supposed to be serving, and this is how we're serving them.
And that information is available. Some of it is available. We can slice those data in a myriad of ways, right? And look at it in
Let's
many
have an
different ways.
offline conversation.
Sure, but right now it is available in our demographic report where you'll see that those relative to chronic illness, and as well as geographical locations of those folks with chronic illness, the top clinics that they utilize.
And that's going to be recent as of?
It's recent
22?
as of 2019. And
okay, 19.
Actually, no, I'm sorry, 2020 data. And it'll get updated again soon, but we can create those more frequently.
Thank you.
So I want to ask the same question maybe in a different way. So if we add together the patient visits, the first outpatient and then the total hospitalizations, that's the final numbers. That we're serving more. Is that correct, Mr. Giesland?
We haven't done that look. That is not the look. We don't include usually the hospital utilization in those charts.
Well, I mean, if we look at these numbers, it doesn't look like we're providing more care. It looks like we're providing, okay, it looks like Seton is, I'm not sure, it looks like that Seton is providing less care for our patients, but it also kind of looks like we have less patients asking for care, if you know what I mean.
Right. So to be clear, we are, through our programs and the funding that this board has approved, you are providing more care to more patients overall. But when you start discerning this, and Sarita, I'd ask you to correct me on my terminology so that it's articulated properly, but once you start slicing up the data and you start looking at it from this different angles, you can't jump to the conclusion that, okay, what I'm seeing here invalidates what I just saw on the overall levels of care that we've been historically has been going up, both in patient counts as well as volume, and then is projected to continue to go up.
And again, this is a representation of primary care utilization. Doesn't include any of the ambulatory surgical centers where services are provided, or any other diagnostic centers. That it just speaks to primary care.
Yes, Manager Mawani.
So what I'm hearing is like we're taking deep dives into some cross sections of the overall data. We shouldn't make any overriding assumptions around some of these deep dives that we're looking into. And so I just want to make sure I'm seeing this correctly. In the deep dives, it seems then that what we are seeing is that when we're looking at maybe specialty and outpatient utilization, those may be just within the scope of that deep dive, right? In the vacuum, those trends may not be trending upward, but rather downward in the whole universe. And then when it comes to ED and inpatient utilization, those may be trending upward, or at least they're on trend, but not going downward, or
right. So
there's a delineation between those two, I feel like.
And again, those COVID years sort of, it appended any kind of trending that we might have seen, right? With those 2 years. But, and certainly we saw a really uptick of utilization in 2019 that at the time we didn't understand why that happened either. Yeah. We went out and looked at, any information available publicly regarding any changes in immigration laws or any changes that, something that might account for why we saw an uptick of utilization and enrollment in that year, but a significant one. It wasn't trending along, as we saw from prior to 2019 to see that uptick. But the trending down happened again because of COVID, presumably. But we are seeing a rebound now.
Okay,
In
so
22 we saw a
post-COVID
rebound,
increase
and then 23
when it
we're
comes to
seeing
ED and inpatient sort of utilization.
Right.
Okay, thank you. This is really, really interesting and helpful. Thanks a lot.
Thank you. Any more questions? Manager Martin.
As we know from primary care, the primary care visits dropped dramatically because of COVID. Hospital utilization, in fact, went up quite a bit with all the COVID admissions. There were some elective procedures that were stopped, but hospitals were overrun with patients. So I think that if you look at the numbers here, you adjust that for what the COVID pandemic, I think that'd be reflective of any clinic situation. So thank you.
You know what isn't reflected in these numbers are the efforts around COVID vaccinations too, and they're not counted among these.
Any further questions? No. Thank you.
Just one statement.
Yes.
So Mike or Olivia and Jonathan, one of the things that would be of great value to us as a board would be to see, okay, our targeted population is 200% FPL and below. So this is a baseline. This is what we're doing every year. This is how our patients are, this is how many patients we serve, MAP, and that's easily disaggregated. MAP, MAP basic, MAP basic. MAP or MAP basic. Where are they being seen? What services are they accessing, and where are they living? And then watch that over year, because to me that's also could be something that we could look at is what strategies are being used that 20 million people are coming here and 5 people are coming here. It actually could be the services that are being provided is the case, as opposed to a high diagnosis of some diabetes or whatever. But it would also help us look to see where we need to improve our targeted campaigns to enroll and do the knocking on the door and the boots on the ground to make sure that we're getting the population that we need to get and that they're actually getting served. Maybe it's too simplistic to state, but that's what I almost feel.
Yes, and I think one thing that may help is our analytics. It's improved tremendously. I want to publicly thank Sarita and her team for. It seems like every time I look up, it's just leaps and bounds. We had different ways of looking at things and different data sets. But I think next time we come back and present this, to go back to what we presented prior, so you can see. Then maybe we'll do a little bit more of a crosswalk, because we've done just that. But it's several presentations later, and you're but maybe go back and recap where we are, so that way you can follow through with the presentation.
Or just send it to us.
Yeah.
Read this. Thank you.
And those maps we have online too are really useful in that regard as well. And we do work with our comms team pretty frequently, sharing some of that information with them too when they need to do that outreach.
I appreciate that. We used to have a map back here that I asked to be placed there, and it was so that we could see where we're serving, who we're serving, and we as a board who may not necessarily know where these zip codes are or the census tract information is, we would at least get a feel for, oh, it's Northeast, oh, it's Rundra, oh, it's here, oh, it's there, oh, it's, Del Valley, or it's Dove Springs or whatever. And I think maybe we ought to bring back the map. Maybe put it over there. Thank you.
Thank you. All right, for our last item, we're going to confirm the next Strategic Planning Committee meeting, date, time, and location. Our next Central Health Strategic Planning Committee meeting is tentatively scheduled on Wednesday, October the 18th, 2023 at 1 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I am ready to accept a motion for adjournment. Manager Musaitif, You're not on the committee, oh, sorry. Manager Bell, and second, thank you, Manager Valadez. So we are adjourned.
Need a motion.
Oh, a motion, please, sorry, everybody
It's not
vote.
a motion. You need a
Remember why I
vote.
can't, a vote, please, yes. A vote, okay.
Aye.
Aye, okay, thank you so much. Okay, this is the first of many meetings tonight, so.
Dear members, we're gonna take a few-minute break for you guys to,
Give them an exact, not a few. When do you want them back?
so, 6:15, is that
Six what?
15? 6:15.
6:15.
That will give you 11 minutes.
Okay.
So if you need a break, grab some food, and we'll convene at 6:15. Thank you.
Wolf down there. Right? You wolfed down
I did. Good afternoon. Today is September 6th, 2023, and it is 6:15 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, well, actually all our board members are present here today, so I do not need to make that announcement. But I'm moving forward with public communication. I believe we already completed that, correct?
Correct.
So we don't have any additional public speakers. Okay, thank you. Before we begin, I would like to reassure the members and the public that Central Health, our board, and this committee strive for transparency regarding the annual budget and tax rate setting process. However, due to ongoing litigation, there may be certain budgetary items that we cannot discuss in open session, and we may need to have a closed session where some of these questions may be answered. We will now proceed to the Budget and Finance Committee agenda. Item number 1, approve the minutes of the August 23rd, 2023 Budget and Finance Committee meeting. Do I have a motion? Manager Brinson?
Yes, I move that we accept the meeting minutes from the
August 23rd.
August 23rd.
Thank you. Do I have a second? Manager Valdez? So I have a first by Manager Brinson and a second by Manager Valdez. Any discussion? I see none. All in favor?
Aye.
Aye. The motion passes. Thank you. Item number 2, receive and discuss a presentation on the proposed Central Health fiscal year 2024 budget and tax rate, including the impact of potential changes to the proposed 2024 budget, tax rate, and future delivery of health care. For this item, we will have Jeff Canoto, Kim Johnson, and Mike Giesling will be presenting. Welcome. Please proceed.
Thank you, Chair. Jeff Knodel, Chief Financial Officer. Tonight, we're here to present our fiscal year 2024 budget. I know that we're possibly a little pressed for time, so I will move through slides fairly quickly. So, we're requesting action at the upcoming, later scheduled Central Health Board of Managers to discuss and take appropriate action to consider approval of the fiscal year 2024 budget with a total tax rate of 10.0692 cents. And that tax rate consists of 2 elements, maintenance and operations tax rate of 9.6071 cents and a debt service rate of 0.4621 cent. These are rates per $100 evaluation. And then the second piece of the second request for action would be to actually approve the fiscal year 2024 budget. And again, that action will come at the Central Health Board of Managers meeting. So this is our budget attachment A. You've seen this before. There are no changes from the last presentation. Again, the budget reflects about a little over 530 FTEs. Our beginning balance of $470 million. Total revenues, which the majority of it is property taxes, so 336 million. And then our expenses that you see outlined, healthcare delivery being the primary majority of the cost. And in addition to that, our contingency reserves that are appropriated also. In addition to that, you see our emergency reserves that are increasing slightly this year at $46.7 million. Next slide. So again, no changes from our last presentation. This is attachment B that gets into a little bit more detail. You see our purchased healthcare services of $141 million. Again, our direct healthcare services, 29.2. And again, this is the epic, the epic of beginning our direct services provisions at Rosewood, Zaragoza, our multi-specialty center that will be where those direct services are delivered. Next slide. And then also within our healthcare delivery program are all the operations that support operations that total out to $114 million. Next slide. This is our administrative program. Our budget for fiscal year 2024 is $28.6 million. And then you see the University of Texas affiliation agreement payment. Again, this is the full $35 million that's budgeted for fiscal year 2024. And then, as I mentioned earlier, the increase to the emergency reserve of a little bit over $8 million. Next slide. So you've seen this slide before. This is our reserve slide that characterizes how we look at our long-term view of our financial position, how we ascertain how to set our tax rate, and we really look at trying to set our tax rate based on a lot of assumptions. And we really look at trying to keep our tax rate level over the period. And that's what this forecast does. As you can see on the reserves, you can see that their reserves are declining over the 7-year period. That's the blue line in the graph that you see below. And then you see for the next several years that as we look at what our revenues are, our spend is greater than or our expenses are greater than our revenues. And that's the gap that you see, and that's one of the reasons why our reserves go down over the 7-year period. One of the things that you would ask, and that's been asked a number of times, is why is it that we're building our reserves up? The board has recently approved the health equity plan, and that's a significant spend over the next 7 years. And that's what's represented in the graph above. These are the incremental costs year over year that are accumulated throughout the 7-year period. And these are ongoing costs. These are not one-time costs. These are ongoing costs that is one of the primary reasons why that we Central Health were building our reserves out to develop a plan to fix the gaps in our healthcare system. And we've engaged a third party. It's been a 1.5-year process, and as I mentioned, the board recently approved the plan. But I know we have a little bit of work to do on some of the key performance indicators, and I think you'll hear a little bit about that later tonight. But this is a significant spend. And so when you think about reserves, you think about, in addition to that, why are we, why are we building our reserves up? Central Health has a risk profile. All entities have a risk profile. When you look at Central Health, there's a lot of things that we know. There are a lot of things that we don't know. When I look at a risk profile, and especially over a 7-year period, we have current risk, we have risk we hold today, we have long-term risk, we have known and unknown risk, and we also have a lot of risk that we don't control, and I think we've seen that over the years. There really are a couple of other types of risks that Central Health has that I'm just going to expound a little bit on. And I alluded to this plan that was recently approved. This plan, when we looked at trying to cost it out, the overall incremental accumulated cost is hundreds and hundreds of millions of dollars. And you see in fiscal year 2030, we have, I think it's 100 labels in the way, but I think it's $146 million of costs in that year. Again, these are ongoing constant costs that will continue to grow over the time period. Again, these are fixed costs over time, and these are big costs. There's a lot of potential deviations that will occur. I'm not talking about we're going to change the plan. I'm just talking about assumptions that we make over the 7-year period are not going to be exactly what this is going to be. And even when you look at, any deviations of margin plus or minus 10%, that's a big number. We don't want to miss that number. We want to have the sufficient resources in order to implement this plan. In addition to that, other types of risks that Central Health bears, and this is not an exhaustive list, and I know that I've talked a little bit about this before, but financial risk, there are a couple of major financial risks that Central Health holds. One of those risks is our contractual relationship with Ascension, the value of services risk. Value of services is those funds come to Ascension, and the value of services is satisfied through the payment of disproportionate share and uncompensated care. Our agreement with Ascension runs through 2038. One of the things that we have seen both recently and in the past is the recharacterization of some of the federal funding programs. If uncompensated care is ever reconstituted or renamed or reprogrammed, there's a risk that a value of services shortfall could occur. And so the question might be, okay, well, what does that look like? So in our agreement, our value of services started at $73.6 million, and beginning in 2019, it's inflated by a medical inflator. It currently sits, and this isn't a precise number, but it currently sits around $85 million. Now, we don't have a value of services shortfall. Uncompensated care has been approved through the state through 2030, but there are still, even just purporting that things stand still after 2030, there's still an 8-year period where you would have to ask yourself, what happens to uncompensated care thereafter? We just don't know. So, but that's a big risk. Again, keeping in mind that the value of services amount inflates every year, and just doing some simple math, it's probably fair to say at At that time, post 2030, it's probably will exceed over $100 million. Insurance risk. We Central Health owns an insurance entity. Just the nature of the insurance entity is risk. What kind of risk do we hold owning an insurance company? We're in the ACA. Risk adjustment is a big risk just related to how that program works and trying to balance out membership. We've also talked about financing the claims cost in our CHAP high risk program. We've had a third party that has historically performed that function for us. We don't know to what extent Central Health may or may not have to step into. And then just capital levels that are determined by the Texas Department of Insurance. So these are all types of risks that are out there for any insurance company, and Central Health as the owner, this parent of Sendero, that exists. Workforce. If you probably ask any provider entity what is their number one risk, what's their number one concern, they are probably going to say workforce. We're getting into specialty care. It's highly specialized, highly competitive, and it's competitive even to have the support staff to support operations around specialty care. This is going to be an ongoing risk that we'll have from day one and moving forward, is just competing with other entities to bring the specialists, to bring the providers that we need in order to provide the services to remedy and resolve the gaps that have been identified through our work in our healthcare equity plan. And then simply, last but not least, legal and regulatory. And I mentioned a little bit about some of the federal funding changes, but any supplemental funding change can be sudden and can be complex and can be substantial. So that's definitely a risk that we hold. And then last but not least would be any future tax caps that we've seen that related around other governmental entities. Hospital districts have not been impacted with the same rights that cities and counties are under, but that was a rate that, or a risk that could impede our ability to fund the services that we planned on funding in the future. So this is just a little bit around some of the reasons why we accumulate reserves. You, the board, have been very insightful in building reserves up in a manner that allows us to have the resources to develop the plan that you've approved, and to also have some capacity to undertake some of this risk assumption that I was talking about. But anyway, I just wanted to try to address a question that we get quite a bit on why we're accumulating our reserves and what the use of those are. Next slide. So our tax rate, again, as we mentioned, we're seeking approval tonight. This is just the standard average homestead value impact from the previous year. And you see that the average homestead value has gone up from $427,000 to $475,000 in this fiscal year 24 period. And then aggregately on the tax bill side, the difference is about $56 from this year when you combine both the M&O and the debt service rate related to the homestead values for fiscal year 24. And then just as a reminder, both the board and the Commissioners Court approved additional or increasing the local homestead exemptions for over 65 and disability, and just noting that at our tax rate, the savings on that is about $125 related to our tax rate. Next slide. And then this is just another view of taxpayer impact by different bands of value. So the way this this table works is we start out at $150,000. It's a home. These are all homesteads, so they would have the 20% homestead exemption. And then we appreciate the value. The appraisal district gives us the appreciation value of each band, and so we increase that and then look at the change in the tax bill over last year. You can see that it ranges anywhere from $12 to $79, depending on the value. Our range goes up from 150, and these are in $100,000 increments up to $850,000. And then this slide you've seen also, but this really is a more simplistic look, a more linear look at a 5-year period where we start out in fiscal year 2020 at a $350,000 value homestead. The assumption would be, homesteads are capped at a 10% value increase year over year. So the model we ran was, let's just increase it 10% every year and see what that looks like. So we're increasing the value 10% every year, and then we've applied the homestead exemption and then the applicable tax rate up through 2024, our proposed rate. And you see that, in fact, between 2022 and 2023, even though there was a 10% appreciation in the home value, the tax rate went down, and in this case, the tax payment went down on the homestead. But what you see in the last 3 years in that yellow shaded area is that the increase in the tax payment is about 4.5% annually. Next slide. So as part of our proposed budget, and I'm not going to spend much time on this, but as part of our proposed budget, at the very end, we typically list out our providers that we anticipate contracting with over the fiscal year. These will be primary care, specialty care, behavioral health, and pharmacy. And so this is a list of those providers, and post-acute, sorry, I missed that. So it's an exhaustive list, and as some of y'all that may have been on the board for a while, it's a pretty, the list is getting longer and longer as we expand out our services, particularly our contracted services. Next slide. And so this is the budget calendar. It hasn't changed a whole lot, other than if you go to the next slide, again, there was a change for the county commissioners, the Travis County commissioners. We were initially scheduled to go over tomorrow for a work session, and that's been changed to September 12th, which is not a work session, it's a regular session. But it's a long list, and we're heading down the home stretch on a number of these meetings, but it's been a long, comprehensive process. Next slide. So that concludes our presentation. Be happy to answer any questions. And I know there's a potential that, and I'm going to take a little liberty here, there may be a potential that there may be some amendments that may be proposed. What I would request is that we wanted to use the budget finance presentation as a way to tee the presentation up and get the information out. And then, and it's certainly up to the committee chair, but we wanted to do that in order to have the discussion at the Board of Managers meeting, which would follow this meeting. So that would be my suggestion as far as a protocol is we'll set the stage on here's where we're at on the budget, and then potentially have that discussion as we go through the approval process and look at that.
First of all, thank you so much. Just want to thank you, Mr. Canoto. Thank you, Kim. Thank you to your entire team for for your hard work that you've been working on for the past year. Appreciate it. As you alluded to, that we have a few amendments. I want to give some members at least some time to digest the amendments. We are gonna, I'm gonna probably give each one of those at least 5 minutes to give the board members some time to absorb before we have a full discussion. So during our Budget and Finance Committee meeting, we are not set for any action item given where it is, but we are just we're just gonna think through the process. So I will, I have members, there are some amendments before you. Hope that you've had the opportunity to read them. Some who've had opportunity to look over for a longer period than others. There's one that was just presented to us today. So I am gonna go with the first amendment by Manager Kitchen. I'm gonna give you about 5 minutes if you had wanted to just go over your amendment, and that we can discuss further at our budget and at our board meeting.
Okay, I will start.
Yes, Manager Valdez.
I'm sorry, I don't mean to interrupt. However, we don't have the presentation that you gave us. I'm missing several sheets. I don't know if anybody else is. So I'd like to have the complete presentation, and that'll help me better explain the, maybe it's in the updated presentation where I'll see what the revenues are and what the expenses are, because I know that's not what it is. The expenses you have is 744,209 and 379. I don't think that's the expenses. I think that may be the.
Well, again, we're.
But I think maybe in the updated presentation, maybe you have them correctly. Maybe I'm not seeing something, and so I'll just hold off and wait for the new sheets.
Yeah, there's a couple of slides that aren't in our background.
Yeah, that's right. So when we get the slides that we're missing.
Okay. Well, there may be a couple of slides, but they've been slides that we've presented before.
Yeah, so, I know, but I like to have it in front of me.
We don't have them in front of us.
Okay. Copies of that, but I'm looking at the packet and nothing has changed on the proposed budget.
Okay, so
you see, can I just walk through expenses real quick? Just
well, I didn't want to. Ann is the one who was called on, so I'll just wait.
Okay.
Thank you.
Thank you, Mr. Canoto.
So about 5
Manager
minutes?
Kitchen, can you explain your motion, what it is? That's the only, I just want you to explain it, and then we can hash it at the Board of Managers.
Okay.
So that's fair. Thank you.
Okay, so managers, first I'm going to take just a minute or two to explain the reasoning and the thinking behind it, and then I'll do a high-level walk you through the amendment so you know what's there. So the first thing is I'm bringing this forward because there are two important goals here. One of them is our support, Central Health support for behavioral health services, aligning our mission with integral care missions to serve low-income folks and providing behavioral health services. That's number one. Number two is taking care of an immediate need with certainty for integral care. As you all know, there's an immediate need for at least $7 million for integral care. The fiscal year 2024 budget, which is a public document from Integral Care, noted that there was a loss of $22 million by Integral Care. The part that I'm focusing on is the $8.6 million for operations, and that has resulted in a drop in FTEs and in a RIF. The total FTE change for the program is 89 FTEs. And that has also resulted in cutting specific programs, such as the programs that are listed in the amendment, or some of the programs that are listed in the amendment. So I'll get to that. So that's the reasoning. So I think it's important to take immediate action, in a way that the patients can see from integral care, that they can feel some certainty. And to me, that means a dollar amount, in a way that those employees, the FTEs that are being ripped, those folks at integral care can see that they can still have a job. Someone just mentioned the importance of workforce. Mm-hmm. The folks at integral care are specialized professional workforce. We don't want to be losing those folks. And it's also important to be clear with the public. I don't think we can have that kind of certainty without a dollar amount. So I am proposing $7 million with language in here that authorizes our staff to go higher than $7 million if that's needed to avoid disruption or delay in services. And I just want to set the stage for folks. We're talking about $7 million out of an almost $400 million reserve. I want to remind folks that we added to our reserves this time almost $63 million in reserves this year. Reserves are important. I support us having reserves. But $7 million out of $386 million, I do not believe is going to hurt our long-term plan for our health equity for our health equity plan. But the other thing is, these services that my budget amendment is proposing are within that plan. They're services to align with our mission and with Integral Care's mission. So just very quickly, what this amendment does. The first part of the amendment actually is the amendment to the budget itself. So it's taking action on the dollar amount. It's actually changing our budget to take that $7 million out of reserves and put it into specialty behavioral services, which is where this would fall. The second part of the amendment goes through a process and I'll go over some of it. It's it names the $7 million. It makes it clear that what we're talking about is for program services that intersect and align with both Central Health's and Integral Care's missions. So we're not talking about doing anything outside of what our mission is. To enhance services for low-income residents and improve health equity. And then it sets up a process for the Central Health CEO and the Integral Care CEO to determine exactly how to allocate that $7 million, to determine what the appropriate program services are, and then report back to the Board of Managers, report back to us by October 4th, the programs identified and how that allocation is set out. It includes a list of programs that are, it's deliberately says such as, so this list of programs are ones that I'm aware of are being cut or they're losing FTEs. But it's written such that there's discretion and flexibility for the respective CEOs to determine how much goes for each of these. So, crisis hotline, if you'll bear with me 30 seconds. Crisis hotline services are very important. Continued MCOT services, there's FTEs being cut there. System of care services, the mood treatment center is being totally cut, etc. So you can see them here. And then the very last part is what I referred to, that it allows for some discretion if after the CEOs have this conversation with the staffs and determine that $7 million is not enough to avoid a disruption and delay in services, additional amounts could be authorized. Thank you for bearing with me for another second or two.
No worries. Thank you, Manager Kitchen.
Okay.
Manager Valdez. You have 5 minutes.
Okay.
Can I just say something, Chair? I know we're not discussing it. I just want to
Yes.
go on the record that I'm supporting Manager Kitchen's amendment.
Thank you for that. Thank you.
I'm going to be briefer than that. For once in my life. Okay, Dr. Bell. You all have seen the sheet here. It's self-explanatory. And one of the things that we're trying to do, and that I'd like for Central Health to concentrate on, is looking at what I forgot to mention here is that it's not only for Latinos in Central Texas, but it's Latinos and those populations that do not speak the English language. Those are the majority of our MAP population. They're the majority of the population that we serve, that we're supposed to be serving here at Central Health. And we do have a high non-utilization amongst our population, especially the males and children. So I'd like for us to look at this. It's $125,000. I'm not asking millions. It's $125,000 that I'd like for Central Health to allocate and work with. I'd like to work with Central Health to help develop this program that would hopefully become its own entity under Central Health, if at all, or if not separate. But taking in the information that research has already provided by the National Institute on Minority Health and Health Disparities, with Salud America, with other entities that have done great research in what Latino and non-English speaking populations are having to face, those huge barriers, their disparities. And this would also show us what we can do or what we can have in place, what strategies we can have in place to assure that the population is being served appropriately, culturally and linguistically. That's basically what I'm asking for. The details are not great with respect to the growth of the program, because it is something that I would like for Central Health staff who are better positioned to be able to look to see what is necessary. We have ideas. I have spoken with Mike about this a few years back, and it did not happen. Twice we tried to get it introduced on the agenda. It didn't happen. But this time I'd like to make sure that it is placed on the agenda and that we can look at it and that we can bring a new initiative to fruition for Central Health that shows to our non-English speaking communities, all of them, that Central Health is committed to overcoming the barriers that they have had to address in the past, and what they continue to address as they move forward in their lives, not only facing the legal issues, immigration issues, housing issues, the job issues, whatever, but all of this has impacted their psyche, their psychological well-being, not only of the parents, but of the children. And you'll see that by the increases in mental health and behavioral health needs, but also in the utilization, especially of our males, not utilizing the clinics and rather going to the emergency department, as it has been well documented. So I'd like for you all to consider this. It's only $125,000. We'll see how it goes, and we will be able to monitor Central Health staff, and we'll help them in making sure that this program is implemented. Thank you.
Thank you, Manager Valadez. We have another amendment. Manager Jones?
Thanks very much, Chair. I'd like to just briefly highlight the amendment that I'm making to our budget. As you're aware, we have worked with community care in the implementation of a Black Men's Health Clinic. That clinic has been underway roughly about a year. It has made some strides, but it's just in the beginning stages. And so what I'm interested in doing is augmenting our funding that we make available by way of community care to increase that to a limit not to exceed $500,000. Now, what does that do? Currently, funding is available to do outreach, to get men of color, and I want to emphasize the clinic is the Black Men's Health Clinic, the focus is on all men, or particular men of color. So I don't want us to understand that we're restricting certain men based upon color, but the focus is that population. Currently, we're doing outreach, and they've done, the founder, Mr. Larry Wallace, is here with us today. They have done some great job in terms of getting out in the word, getting the word out. The question then becomes is, okay, now that we've gotten their attention, how do we see them? Currently, funding is only available for 1 day, and really that 1 day present problems because men of any color have problems being able to say, okay, you've got to be here on every Friday, and this is the only time we can see you. And so as a result, we need to give them more flexibility. These additional dollars will be able to provide services. The expectation will provide services, clinical services, and support services to add another provider and maybe some more support staff so that we'll be able to provide services on multiple days of the week. I believe in terms of trying to address this disparity issue to my colleague, Manager Kitchen, these funds particularly, as we look long term for equity, this should be something we need to look at as well. But for this year, my goal is to augment what we're currently doing and encourage the development of expanding services for this population. I think that's basically overall what it is. I'm not asking for us to create a new arrangement with community care. I'm just asking us to augment some more dollars up to $500,000 to achieve that.
Thank you, Manager Jones.
Thank you.
So managers, I wanted you all to have an opportunity to think before we discuss these at our Board of Managers meeting. And as far as I know, those are only the 3 amendments are on the table to amend to our current budget. There is another amendment that is built off last year that is cancer related, does not have any budgetary item behind it. So that's not going to be, I'm not going to state it here. Following up to our speaker that came before us today, the Sobering Center, there is potential. Initially, I was going to propose an amendment that's to direct staff to start a conversation, but they're already working on it, so I commend them on that effort. And the Sobering Center is coming forth to our committee to discuss their program further and what their funding may need. So that is for future discussions, and I appreciate them coming and speaking before us. So do I have any questions really quick, not related to those amendments? We'll discuss them at our meeting. If yes.
Could you hear this question and tell me if you think it's a this meeting or that meeting question?
Do you have a question?
Yeah.
Sure, go ahead.
It was around particularly the amendment motion around the Central Texas Latino Family Support Conference, and not the other 2 amendments around this one. I wanted to ask if there is a budget line item that may already exist. That's the next meeting? Brilliant. Forgive me, Chair. Thanks. Mm-hmm.
Thank you, Manager Matwani. Thank you, members. So at this moment, I am gonna end this meeting, and we'll proceed to our other 2 meetings. But again, wanted you to have an opportunity to think these through, and we'll discuss them further. Thank you, Jeff. Thank you, Kim. Thank you all. And at this moment, I am going to confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, October 25th, 2023 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment. Manager Matwani, motions. Manager Jones, seconds. Any discussions? I see none. All in favor? Aye. Meeting adjourned. Thank you.
Good afternoon, members. Today is September 6, 2023, and it is 6:59 p.m. As a quorum of the committee is in attendance, I'd like to call to order a meeting of the Central Health Executive Committee. The first item of business is public communication. We received public communication for all of our meetings today prior to the Strategic Planning Committee, so we will proceed to the Executive Committee agenda. Members, due to anticipated time management issues in the Board of Managers meeting, I will not take up item number 3. Item number 3 is discuss and take appropriate action on oversight of Central Health funded entities and others to which Central Health Board appoints governing and advisory members. We will consider this item at a later meeting. Agenda item number 1, approve the minutes of the Central Health Executive Committee, July 26th and August 23rd, 2023 meetings. Manager Musaiti. Oh, I'm sorry, Manager Valadez, do you have it in front of you?
Yes.
Go ahead.
Approve
You move.
I move that we approve the minutes of the Central Health Executive Committee meetings for July 26th and August the 23rd, 2023.
Thank you. Manager Musaiti.
I second.
I have a motion from Manager Valadez. I have a second from Manager Musaiti. Any further discussion? Hearing none. All in favor? Any opposed? Any abstaining? Motion passes unanimously. Agenda item number 2, review and provide direction to staff on the prioritization and tentative scheduling of items for consideration at future Central Health Board and committee meetings. Brianna Yanis will be presenting.
Okay, I won't go through all the items, but I will point out that we, in addition to our October meetings, I do have on the calendar now an ad hoc succession committee meeting scheduled for October 16th. That will be for candidate presentations, and then on October 30th and 31st, I blocked all day for first round interviews for the CEO. And then we're also going to have an ad hoc board appointments committee meeting on September 11th, which is Monday at 2 p.m. And that's all I have, unless anybody has any questions.
Any questions? I do want to let the board know that it's getting to be that time of year, so in addition to those meetings that Brianna outlined, I will be establishing a nominations committee to nominate candidates for our executive committee and executive positions. So that will happen soon, and we will let you know. The bylaws outline who's to be on that committee, and so we will follow the bylaws and appoint as appropriate. We also will be scheduling soon an exit interview for our current CEO, and I look forward to having that discussion with you, Mike. And as Brianna said, the succession committee is going to meet and also have interviews. Any further questions? Okay, hearing none. Thank you very much, Brianna. Appreciate it. Agenda item number 3 is to confirm the next regular executive committee meeting date, time, and location. Manager, our next Central Health Executive Committee meeting is tentatively scheduled for Wednesday, October 25th at 4 p.m. or immediately after the Budget and Finance Committee meeting at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. I recognize Manager Valadez for a motion to adjourn.
I move that we adjourn.
I recognize Manager Brinson for a second. I have a motion by Manager Valadez. I have a second by Manager Brinson. Any further discussion? Hearing none. All in favor? Any opposed? We are adjourned. Okay, managers.
Shortest meeting in history.
Managers, we will go into, might be the longest meeting that you've ever had.
No, it won't be.
Good evening. Today is still September 6, 2023, and it is 7:04 p.m. As a quorum of the board is in attendance, I'd like to call to order a meeting of the Central Health Board of Managers. The first item of business will be the consent agenda. Consent agenda item 1, approve the minutes of the Central Health Board of Managers, August 23rd, 2023 meeting. Consent agenda item 2, receive the quarterly investment report and ratify Central Health investments for August 2023. Do I have a motion? Manager Valadez?
I move that we approve the minutes for the August 23rd, 2023 Central Health Board of Managers meeting, and also receive and ratify the Central Health Investments and Investment Report for August 2023.
Do I have a second? Manager Jones? I have a motion by Manager Valadez. I have a second by Manager Jones. Any further discussion? Hearing none, all in favor?
Aye.
Any opposed? Any abstaining? Motion carries unanimously. We will now proceed to the regular agenda. Members, as we deliberate and finally pass our budget, we want to do so in an orderly way that allows everyone to provide input. Please work to make your presentations and questions to be concise to ensure efficient time management. Also, please only speak after you have been recognized by the chair. And since the amendments and explanations were outlined in Budget and Finance Committee, let's please try to limit our discussion to questions regarding those amendments. Okay, we're on to the regular agenda. Agenda item number 1, discuss and take appropriate action on the proposed amended mandatory payment rate to be assessed on institutional healthcare providers during fiscal year 2023 under the Local Healthcare Provider Participation Program, LPPF, in Travis County as required by the Texas Health and Safety Code, Section 298E, .151. Katie Colburn will be presenting. Thanks. Hi, Katie.
Hello. Good evening, managers. I am back once again. I've never seen this one before. Okay, is that better?
Yes.
Okay. I'm back again to request your all's action to approve another amendment to the fiscal year 23 Local Provider Participation Fund payment rate. If you want to go to the next slide, the action request we have is to take the rate up to the legally allowed limit of 6%. The reason we are coming back and asking for that right now at the end of the fiscal year is 2 new supplemental payment programs have come online and will be available to institutional healthcare providers in our community, and we want to be able to make sure we can draw down full federal funds with those new programs in place. And I know you all are fully aware of this, but just for the benefit of the public, I want to make clear that the fund that we hold these mandatory payments in is entirely separate from the central health budget and functions outside of the budgets and work that you all are approving tonight. So just to make that clear, we can move on. So as we've discussed before, this is a mandatory payment assessed on private hospitals in Travis County. Central Health behaves as the administrator, and we use those funds to perform intergovernmental transfers that draw down federal funds into the community for hospitals here. Our current rate is 3.96%, and the requested amount, as I mentioned, is to take the rate up to 6%. This is information you've seen before about some of the requirements, who is eligible for the mandatory payment, and how the payment must be assessed as uniform and broad-based. And just as a summary, the total amount of revenue, that annual amount of revenue this rate will bring in is about $228 million. This particular payment will bring in about $78 million with this increase, and that will cover these 3 programs. And I'm happy to take any questions.
Thank you very much, Katie. I do have a question, and then I'll recognize the other members. Have we had new hospital facilities come online during this period of time?
We have not.
We have not. Okay, thank you. Manager Valadez.
In the alternative, have we lost any hospitals?
We have not.
Thank you. And then I'd like to go ahead and make a motion.
Let me make sure everybody else questions? I'm seeing no further questions. Please, Manager Valadez.
I move that the board approve the FY or fiscal year 2023 LPPF mandatory payment rate amendment as proposed by Central staff.
And a second from Manager Musaiti. I have a motion from Manager Valadez. I have a second from Manager Musaiti. Any further discussion? Hearing none. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries unanimously. Thank you very much, Katie.
Thank you.
Appreciate it. Agenda item number 2, receive and take appropriate action on the proposed Central Health fiscal year 2024 budget. Jeff Knodel and Kim Johnson will be presenting. Managers, before we begin our voting, I'd like to remind everyone that we've all been advised as needed on our areas of conflict and/or duality of interest. If there are any comments, questions, or concerns about tonight's vote, please reach out to our legal counsel with the county attorney's office or our chief compliance officer, Mackenzie Frazier. The first thing Manager Valadez?
Dr. Bell, is it possible for us to have a presentation of the updated presentation for Jeff Knodel's?
Yeah, we're
Thank you.
distributing those right now.
Thank you.
Thank you.
This is what I was trying to do. The total revenues here. Total expenses. It's not.
Okay.
Okay, thank you, Dr. Bell. I'm just going to run through attachment A and B real quick. Again, the requested action for tonight is to approve both the ad valorem rate of 10.0692 cents and then to consider and adopt the fiscal year 2024 budget. Next slide. And so, again, attachment A, the level of budget that supports both our revenues and our contingency reserve and our healthcare delivery program. Next slide. And again, this is the detail behind attachment A that lays out purchase health services, direct health services, and other program areas in our healthcare delivery program. And then the next slide, our healthcare operations and support. And then last, our administrative program, the UT affiliation payment, and then transfers out that this year just is a transfer out to our emergency reserve fund. And let's see, next slide. Yeah, next slide. Good. And so I think that's our presentation related to the budget, just kind of reiterating what was presented at the Budget and Finance Committee meeting a few minutes ago. Thank you, Dr. Bell.
Thank you very much, Jeff. I appreciate it. Any questions before we start the voting process? Manager Valadez.
Okay, thank you very much, Dr. Bell. but it doesn't appear to be it would be the sources, I'm sorry, revenues, 336, et cetera. Expenses, 744. What is the number that's supposed to be there?
Okay.
I think it's like, isn't it something else?
No.
Okay, so then explain it. Sources and uses, revenues and expenses. What would be the expenses?
Well, the total expenses are the 744,209. So let's just, can I walk through this?
Yes,
a little
please.
more detailed. So this is in a format. We've revised the format to correlate almost exactly with the county's format. And so, let me walk through. So we start out with a beginning balance.
Yeah.
Up at the top, the 407, and that's the contingency reserve amount from the previous year. So that's rolling forward. I don't know if y'all remember, there used to be a contingency roll forward. That's instead it's beginning balance. It's just recharacterizing the description of that.
Okay.
So there's nothing different than what we've done in the past.
I get it.
It's just a format change. And then we're showing the revenues. So property tax is the majority of those revenues, and the total revenues total to $336,479,311. And so when you add the beginning balance and the revenues, the total of that is the 744,209,379. That's what we're calling available budgeted resources. Again, this is verbatim exactly what the county calls it. On the expense side, our healthcare delivery program, administrative program, our UT affiliation agreement, all the expenses transfers out. Historically, we had budgeted contingency reserves in the healthcare delivery program, but we're breaking that out and breaking it out in its own separate line. So that's the kind of the remaining balance related to the available budgeted resources. And so when you add all that up, the total expenses, the total appropriation is the same amount, 744,209,379. So that's mechanically how that works.
I understand what you're saying. I'm in my head. I just wanted to see if we have our revenues, then what are our expenses? I know this has changed because you changed the format here. So what would it have been for revenues? Because there would have been a little bit of a deficit if we hadn't added in the contingency reserves.
Yes, hang on, sorry, I had it written down on another version, and somehow that got lost. 86.
And I noticed that in the presentation, you had said sources and uses, revenues and expenses interchangeably, so that's what I'm looking for.
Well, again, we went to a straight format that is exactly how the county does it to eliminate some of the confusion. The total expenses, so I think what you're asking is what are the expenses less the contingency reserve?
Yes.
And so that amount is.
That's all I need to do is
$357.4 million. And so, and that kind of gets back to, if I can go back to just a slide that we presented earlier, the reserve slide, and when you look at the expenses, when you look at this slide, that's, and again, we use this for the forecast, so these aren't the exact numbers, but that's what we're representing. At some point, we're utilizing reserves, we're utilizing the contingency reserve to balance our budget. So
that was at 357 million what?
$357.4 million.
Okay, thank you.
And so I got that number simply from the 744.2 less the contingency.
Thank you.
Which I think is what you're asking.
Yeah, thank you, I appreciate it. Thank you, Manager Valdez. Any further questions on the budget? Okay. Members, we will take up amendments to the proposed budget first, and then we will approve the final budget. For those amendments that pass, they will be amended to the proposed budget we approve tonight. Just for clarification, we're going to take up amendments to the budget resolution a bit later. I will recognize each manager to outline their proposed amendment as a motion. Upon a second, we will then discuss, ask questions, and then a vote. I now recognize Manager Kitchen for a motion.
Let me make sure I'm understanding. Do you want me to separate the budget from the budget resolution or make them both right now?
No, right now I only want the budget.
Okay. Okay. Then I move that we amend the fiscal year 2024 budget detail Schedule B as follows. Increase purchase health services, specialty care, behavioral health by $7 million. And that takes it up to approximately $20.6 million. And as necessary, reduce healthcare delivery contingency reserves up to $7 million.
Okay, thank you. And I have a second from Manager Musaitis. So I have a motion by Manager Kitchen and a second by Manager Musaitis. Any further discussion? Now, here, members, is where you ask any questions that you have with regard to that particular amendment. I'm going to go around, okay? So, Manager Martin.
Thank you. Thank you, Ann. I have a question concerning this because I think it's not very clear to me. So, Integral's shortfall's $20 million this year, from what I heard. And is this a $7 million minimal that we'd be giving them this year? With what end would it stop? Or is it just a $7 million base and that's it, to be then decided, the distribution by the CEOs is how it goes?
Do you want me to speak to that? Okay.
Yes, thank you.
Okay, so the first part of your question, yes, the integral care budget shortfall is $22 million, but it's important to understand that only $8.6 million of that is operations. The rest of it is capital projects. Okay, so it's the 8.6 that I had focused on, because that's operations, that's program services to patients. So that's the first part of your question. So the detail about the second part of your question is in the resolution, not the budget portion. But what the resolution says is $7 million, and then it has language that allows, that authorizes the CEO to go above $7 million, but there's parameters for that, and there's two guardrails for that. One guardrail is it has to be for the purpose of avoiding patient disruption or delays. And then the second thing is there's a report back to the Board of Managers. So, for example, if the first part of what's in the budget resolution is done for $7 million, and then there's a determination by the CEO that there's still issues around, despite that $7 million, there's still issues around delays and disruption of services for patients, then there's authorization for the CEO to take additional steps and look at reserves if necessary, but to come back to the board.
To come back to the board before approving more money?
Well, let me look at the specific language. It's a reporting back to the board. So my thought would be that it would be report back to the board, but I'm not sure if the language is precise enough for that. Let's see. It says Central Health staff will take steps to avoid as expeditiously as possible such service disruptions to eligible low-income persons and may utilize additional contingency reserves to do so. So it's a may. Central Health staff will report to the Board of Managers Budget Committee on a regular basis any allocation of reserves for this purpose. So, you know, you're right, it's not as precise as that, but, I mean, it could be, you know, you could easily, if that's a concern of yours, if you'd like to say, report back to the board before.
Well, I would just say report back to the board and perhaps offer the board an option to vote on more funding.
Okay,
Because
that could
I'm
be
for
added.
that. I think it's a wonderful idea. I'm just worried about the
Yeah,
guardrail never
you're worried
ends to
about a
some
limit.
extent, and without us getting feedback and then the ability to rescind that and say, because where does it end? I mean,
Yeah.
so
I can work on some language
Okay.
real quick on that.
thank you.
And I would venture to say that any action that we give the staff with regard to increasing any budget item has to be a vote of the board. It cannot,
Is that already in place, or does that need to be added?
for clarity, it probably needs to be added. But
Okay.
Mike, go ahead.
And this would be for purposes of that last B, and I think we could, oh, I'm sorry.
No, Mike, what were you going to say?
Oh,
Oh, no, go ahead.
I was going to put it in that sentence, Central Health staff will take steps to avoid as expeditiously as possible such service disruptions to eligible low-income persons and may utilize additional contingency reserves to do so, provided, however, that the CEO shall report to the board before expending any additional funds. Does that,
Sounds good. You're the attorney.
is that okay?
Yes, just to respond to the first portion regarding the 7 million, the way I would interpret that is, real quickly, the two CEOs get together and determine which programs, and using the list there as a starting point and services, but that it's the express will of the board that 7 million be funded. And so when you look at that October 4th reporting date, it says identified and funded, so it's not prospectively funded. It would be an automatic transfer of that 7 million to a list of programs. And then ultimately that gets reported to the board.
Right,
after
he was
the
talking
transfer
about the
has
second.
occurred. I'm sorry, I heard the 7 million, so that's
Okay.
what caught my ear.
Okay.
Thank you.
And then, if I may, on the second provision, this was language that was pulled from a prior version of a staff level recommendation. But you're absolutely right. I mean, there's not a board vote contingency on this, and so this is rather unique in that it, at least not in my memory, since I've been here, has there been a provision that allows the CEO to expend contingency reserves without a board vote.
That's why we're adding language to require
right.
the vote.
Because my concern is,
I agree with
the
you.
state's not going to give, the state withdrew this money, they're certainly not going to be more generous next year, and we'll find ourselves in this redundant process, and I just would like to put some guardrails around that.
No, I think thank you for catching that.
Thank you.
Thank you. Manager Jones? No? Manager Motwani?
Thank you. And if I could address Manager Kitchen directly with questions, possibly?
Yes.
Okay. So I am curious, and you serve on the board of Integral Care, right? And Dr. Zamora, you're on the board as well. And so for me, this was news as it came out in the news, and then of course, with related to what I've been reading recently, and then of course in the backup. What is the, I guess, so what I've read is that the total budgetary shortfall is around 8.910 million or something like that, or at least anticipated deficit year over year. But so are we saying it's 20 total for operating?
I can share this with you if you'd like. This is the budget document from Integral Care. It's 8.6 for operations.
It's for operations,
Yeah.
right? And so the direct, I guess the state dollars that were expected were something like 3.2 expected from the budget that didn't come through, and then like 1.x million that didn't come from the direct payment program. What would help me is understanding funding sources year over year and where the huge differences are. That's number one. Number two is more around, I guess, it's a management question. How did we not see this? And the reason I asked that question is not because I don't believe that we need to invest every dollar we possibly can in behavioral health services. In fact, I think if we did do that, we'd be all advocating at the state much harder for the resources that are available. But we're here fighting for the crumbs that we have, and so that being said, if we were to make if we were to amend our budget to accommodate a capital investment like this, I'm just curious how we know that it's a sustainable investment.
Okay, so, and Dr. Zamora, you can help me if I get it wrong, but basically, it is, the shortfall is due to a funding from the state under their DPP program, which you may be familiar with. The DPP program for everyone else is a matching program where the LMHAs, basically the state provides money to the LMHAs, they have to turn around and give some of it back to match for federal dollars coming down. That's put into a pot, and then there's a formula that's distributed at the end of the year. And it's a relative distribution. And it has to do with services and other things in a formula to determine how it's distributed. The LMHAs don't know how much they're going to receive until the end of the year. And because it's relative, they don't have any way to track that. They don't know what the other LMHAs are doing. So it's new information for Integral Care, and so that's why. Now there's efforts underway through the state association to try to fix that formula, but didn't get fixed for this year.
And that's about 1.6 million that they had to return.
No, yeah, they returned 1.6, but then they didn't get.
Oh, I see.
Yeah, I can dig into the details if you want to know exactly where the 8.6 comes from, but it'll take me a few minutes to do that because I'm not remembering exactly where all the 8.6 comes from.
The reason that matters is just if we're gonna make that investment and do it in a way that's sustainable, I think we need to know if we're committing forever to just a growing amount from here on out, forever committing to that baseline, and it's just going to grow from here on out. For me, it's really important to know what those sources were and what the viability of being able to replace those sources might be as far as diversifying and just creating sustainable revenue.
There's a couple of guardrails around that in this proposal. First off, the proposal doesn't have anything built into it to have costs grow. The proposal is based on services, which is what we do. It's not a lump sum amount. It's not a grant. It is to pay for services for low-income folks. And it's at an amount, which is $7 million. So it doesn't, so just like any other service we provide, it's not any different than how we might do other things in the budget. So there's no growth to it at all, unless we chose to in the future. Mm-hmm. So, but it would stay at the same amount, okay? Now, with regard to what that has to do with Integral Care's budget, those are longer-term conversations. As you probably know, Integral Care has no independent source of funding. So Integral Care is dependent upon contracts, essentially, with Central Health, with the county, with the city, with the state and the feds for specific programs. So that's the source of it. So when there's an unexpected, and a big one in this case, unexpected yanking of funds, so to speak, or not yanking, that's the wrong word, but shortfall, thank you, of funds, that's what happens to integral care. So I think that future conversations would be great for Central Health to participate in, with integral care, with the city, with the county. I think Mayor Watson was suggesting that. And that would be a great thing for the future, to kind of talk about, well, here's this huge resource, this public entity that we have in our community that doesn't have the kind of surety that our other public entities have in terms of dollar resources. But that's a later conversation. I'm not trying to solve for that today. All I'm talking about is immediate hit on services. So that's all I'm talking about.
I get what we're talking about today. That makes a lot of sense. My concern, and I understand that there's not built-in growth as well. My concern is also that, if I were to eyeball it in my lifetime experience, I know that once a revenue faucet is opened, as good of a cause as it is, it's very difficult often to maybe close it. And I think that there's a high probability that that the amount going through that faucet can continue to grow if I think sustainable guardrails aren't necessarily in place, or at least sustainable plans aren't in place to continue to diversify and strengthen those revenue sources. For me, an amendment of this magnitude, which, let's be clear that I support it, and I support that no interruption in services should be a paramount goal that's shared by everybody in this room. Let's be very clear about that. Now, let's also be clear that irrespective of, I think, some of the challenges faced by LMHAs, we should definitely take care of our CCBHC here, and irrespective of the challenges they face in maintaining diversified and funding that has surety to it, I also would like to think that this kind of shortfall shouldn't be blindsiding us, or not us, but the organization. And maybe I'm missing something, but because we know that funding sources are volatile, right? And so are we counting on that, or was this just a blowaway surprise for everyone?
This was a blowaway surprise because of the nature of the formula that is used for that DPP program. So, and I think that what you're raising is certainly appropriate conversations for the longer term.
Yeah.
But let me also just say, what happens with this in the future is totally up to all of us. We vote on the budget every year. This is no different than any other program. The other thing about it is this program, the way it's written, is it aligns with our mission. So we're not talking about funding a program that isn't something that we would want to do anyway. That's part of our health equity program.
Right.
So, but it's not any different than us saying we're going to fund, some other healthcare service that we've already got in our budget, and so if we're concerned about that healthcare service going up next year, we can decide next year if we want it to go up that much or not. Same thing here. There's nothing in here that builds this in or requires it to go up in future years.
That makes sense. I think, for me, this would have been a lot better if I could have seen, revenue sources year over year, been able to get a better visualization about what changed from here to there, get a better idea of what we're supplementing with the investment and what the likelihood of that being displaced or not permanently is. That makes that for me, a more prudent decision, beyond, of course, the moral imperative of not interrupting what are, again, paramount services.
Well, let me first say, I apologize. I didn't...
Are there any staff or just board members?
Didn't send out this packet to everybody. So I realize that you would, that you and others probably would have liked to have seen that. So, I apologize for not doing that. In terms of the programs, they're listed here, and I can go over them with you. There's.
The programs are fine. I was just, unless you're citing revenue sources associated discreetly with each program.
No,
or
the
revenue sources
the process is that the two CEOs would talk about how to allocate, and because I felt like that was not for us to do, that was for the CEOs to figure out. So I can just tell you that the crisis hotline services, there's FTEs cut for that. The mood treatment center is going away. So all of these programs are impacted. And what Integral Care has had to do, because they haven't had any, any way to handle this shortfall is they've had to cut FTEs, cut programs, cut FTEs within existing programs, and do a variety of things. So,
Well, you know, that makes sense. I guess I just, at the board level, I'm guessing we don't have any staff from Integral Care here.
no, again, I didn't
No,
think that it was.
I just think at the board level, I mean, there was a wage increase, you know, that's very salient that happened in the same fiscal year.
No,
And
it wasn't the same fiscal year.
It wasn't the same fiscal year.
It was last year.
It was last year, and then it affected this fiscal year, which I guess ostensibly has strengthened or at least made exacerbated the shortfall year over year, I guess, when related to funding sources. But I think what I'm feeling is that if at least at the board level, that this kind of volatility, like, and I'm sure that nobody at the board is going to forget if this is a blow away kind of, if this caught everyone off guard. But it just seems like, you know, at the board level, this should be something that sits with all of us for a really long time.
Well, I can assure you it does. Also, I would just say, I raised this issue last week and signaled to the board that I was going to bring an amendment. And at that time, I didn't have the details because it was before the vote at Integral Care. But I wanted to give you all as much, heads up as I could. So I anticipated as much as I could what questions people might have.
Thank you so much. Thank you all for serving on the board and also for stewarding. This is a super valuable resource for our community.
If I may add, Manager Kitchen, you know, as chair of the Planning and Operations Committee, this blindsided us. We really didn't expect this. One of the first questions out of Trustee Reverend Callahan's mouth for any grant, any funding is, what's the sustainability of these monies? And usually, staff is really good about it's there. It's going to be there. So they didn't know it was coming. And so, you know, if any of us read, you know, the Watson Wire, said the Honorable Mayor and Senator has supported this help because we do need it for our brain health.
Yeah, the Watson Wire was compelling, and what's really compelling, frankly, is that you all architected it. Manager Kitchen, Dr. Bell, Mike, and and even Mayor if he was involved. So thank you all.
Well, I appreciate your questions. They're important questions. So.
Yes, thank you. Manager Brunson. And then Mike.
So I want to clarify something. So the $7 million, if we were to approve that for this year, are you saying that would not be an automatic approval from here on out, or are we saying, yes, then this will change our budget line item, because then it might be very hard to decrease our budget line item for Integral Care?
Our budget is never automatic. We vote on a budget every year.
And but we don't often vote to decrease someone's funding.
It's totally up to us what we do with it.
Just putting that out there. The second question I have is, has Integral Care or any other one of our things that we fund besides Sendero had such a large such a large fall deficit in their budget in 1 year? Has this happened?
I
Planned
don't.
Parenthood?
Pardon?
I said Planned Parenthood.
So we funded Planned Parenthood and then they lost.
Then we couldn't fund it.
Oh, then we couldn't fund them anymore. Okay. So as far as you know, Sendero is the only other organization that has had their budget cut. I'm asking the staff, really.
That's the only one that comes to mind. I would say that this goes back before most of y'all were on the board, but it wasn't an entity, but there were a lot of programs that Central Health participated in that required intergovernmental transfers. The Deseret program, uncompensated care, prior to the LPPF, there was some, especially around the Deseret program, there was a point in time where I think the intergovernmental transfers were behind over a year. So it was almost, at some point, in order to catch up, you had to compress 2 years into, I think it was the final year, I think this was 2016. That wasn't necessarily a shortfall, but it was more of a budgeting anomaly. It was part of the reason why we styled our contingency reserve that way, was to accommodate those timings. But as far as any other entity, no, I'm not aware of it.
What is the likelihood that it could happen again? Like next year or the following year?
Well, I think that the actions that the board and others are taking is first to try to address this immediate situation, and then address longer-term stability, which is what I mentioned before. You know, as a community, we need to sit down and talk about how we might help integral care with sustainability, because integral care's only options are when we, you know, if it happens again, they'll have to cut. You know, and it's not a management issue. It is how funding works.
Well, this sounds so similar to me as to what happened with Sendero. And it's very, I mean, you know, they had an unexpected shortfall from an entity going out of the market. So it feels very similar.
Yes, and we're covering Sendero.
Yes, we are. And so I wanted to see if anyone else, any other of our programs has the potential to do this again. And just wondering this, because when we voted on the Sendero, we were told that this could happen again. So just bringing that up.
Well, to answer your question, the best I can tell you is that integral care, a lot of the grants for integral care, you know, they don't have surety around. So.
Okay, hold on. Mr. Geisler, you've been waiting.
No, actually, I'll yield to the board members if there was somebody else down there.
You cited and then
Okay.
Validez.
So, thank you then. Just to comment on some of the conversation, but also I have a question needing clarity on implementation. I do think if I were to, you know, still on my watch, enter into new agreements with integral care in light of the current situation, we would need to see some type of fiscal plan that not only looks at, you know, what are the revenues and what are the expenditures as it relates to, and there's a vested interest here because we really need to make sure that persons of low income who we serve get the services that they need, but also as best possible looking around the corner to see what are those financial risks and how are those risks going to be mitigated. And I do think that there was some element of the current fiscal situation that people did see coming, and it's cumulative over time. But and then there are some that, you know, just because of the way you finally get the pronouncements from the state on what the formula allocations are, they are sudden. But I think taking into account those things that that you can see further down the road, I think having that conversation with integral care management and seeing that to ensure the stability and the sustainability of the services for our patients is going to be critical. And that's commentary on my part. But the other thing that I need to see, would like clarification on, is I've heard different things here about the $7 million. It's my understanding in conversations prior to the meeting that the $7 million gets infused as quickly as possible, and it's by programs identified by the two CEOs or services. Okay, so it's not on a reimbursement basis. It's a direct infusion of funds.
Do you want me to answer?
Well, yeah, that's my question. Yes.
Okay, the $7 million is for program services. We're not giving a grant, we're paying for services. Now, exactly how you guys work that out, you know, I don't know I don't know what the appropriate way is to pay, but it's for services, it's not a grant. So there's that. And, you know, I mean, you know, you have procedures and integral care has procedures, so, you know, I trust y'all to figure that out. So I don't think it's quite fair to say that integral care could have seen this coming. I really don't think that's fair to say.
I said there's parts of it they could have seen coming.
Okay, well, this is not really the, okay, if you want to make that statement.
Okay. Manager Musai.
Well, thank you, Manager Kitchen, for bringing this before us. I've had several discussions with staff and other individuals about this item, and from a staff perspective, I do understand the risks that we have in the buildup and what could happen. At the same time, I'm looking at the immediate need for our community, and rather than us, our mission is to close the gap and not to widen the gap. And it's really disheartening to know the lack of the disruption of services that may impact our patients, and in addition to the massive layoffs that could really have a domino effect in our community, really just continuously widening it. Alongside that notion is, yes, we have this health equity plan that we are forecasting for the future, which is awesome, amazing, but at the same time, we need to work in parallel of the current needs that probably we've all mentioned that we have right now, because patients need it now. They may not be able to wait another 7 years for that service. So I'm happy that we're working in that parallel direction, and I really stress upon that we need to think of closing these gaps and understanding things do happen. There are disruption. There are things that are out of our control, which we've had witnessed in other entities. And we need to support this because there's a critical need, with understanding that there are some caveats and surrounding that we've, like Manager Martin, Manager Mawani addressed the faucet example, that we need to have a sustainable plan where I would encourage or perhaps recommend, if within the budget resolution, to have that parameter that we have I don't know if you want to call it a coalition or however you want it, a task force, really to discuss sustainability of services so these services are not ever interrupted. And that would really take into the responsible parties, the city, the county, us, and others who are involved in addressing the care for our marginalized community. So with that said, and I think every other manager has emphasized some of the concerns, I echo them, but at the same time, I'm going to reiterate, our mission is to address the need for those who need it most and to close the gap and not widen it. Thank you.
Thank you, Manager Musaiti. Manager Valadez?
When I spoke last week, I talked about having just listened to the integral care budget. That struck me. And it struck me because I have a daughter that has benefited from MHMR and now integral care programs for 29 years. And low income, she's her own household. And one of the big complaints in listening to a non-English speaking population or non-verbal population is that it's difficult to keep their workforce in play because they don't offer a lot of money to their jobs. I've seen coordinators change 2 and 3 times a year, and yet it's been 2 years since we see one for my daughter, okay? But that's not the point. The point is we're facing a mental health and behavioral health crisis, and it's a cumulative crisis. It's not getting better, it's getting worse. Economics, you want to call it a pandemic, but uncertainty from healthcare issues, housing market, affordability, blah, 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 everything else, education changes. The quality of life is no longer assured. Education and improvements in how you live and what you get are no longer guarantees that you're going to break the cycle of poverty. But nothing is so core or central to a person as their mental health. Nothing. If you don't have good mental health, if you don't have a nurturing surrounding environment, if you don't have a loving surrounding, compassionate care providers, then you're not going to have nothing. Your condition will worsen, and exponentially. It will worsen exponentially. I have seen it, I have lived it, and let me tell you, this is the best thing that I have seen, thank you, and for bringing it forward. We haven't increased the integral care budget in 7 years by $7 million, just by $7 million. I can't remember in any year that I've been on the board. Jeff, you've been here longer than I have. And I don't remember it ever hovering more than $8 to $10 million. And I have wondered about that and brought it up before. And so I thank Manager Kitchen and Dr. Samota for bringing this to our attention. I hope that everybody supports it because I intend to. But it's one of the reasons I also submitted my little thing.
Sure.
Because if you look at mental health, especially if you're in a non-English speaking community, and poverty and marginalized, this is exactly why you need integral care.
Okay.
So
Thank you very
I
much.
ask you all to please support this.
Thank you very much, Manager Valadez. Manager, you've got yours? Have you?
Just one thing, for council, when we vote, we have to abstain, don't we? Ann and I?
From the integral
From
care.
the integral care
Budget.
budget?
It's
Any funding?
never my job to tell you you have to abstain from anything.
But it would be a conflict of interest?
Not a conflict of interest, a potential duality.
Okay,
So, that in the main budget motion, there is still an integral care,
I just want the public to know
separated
that
motion.
even though we're supporting this amendment, she and I can't
You
vote on
will abstain during the appropriate motion.
it. Right, thank you.
Yeah, and that's what our Sendero folks do,
Yes.
and anybody else that sits on a board. I think that's the only two boards we have.
That's correct.
Okay.
And it used to be Peoples. I was on Peoples, and I would
Yeah, okay.
abstain for that.
I'm new to this.
I'm not on that
I'm
anymore.
new to that, so thanks for clarifying.
Okay.
Mm-hmm.
And Jeff, did you want to say something?
Yeah, I just, before we're ready to vote, I just was going to, for the record, just give where we're changing the budget and just the updated amounts.
Okay.
My apologies.
I want to make one comment, and then I'll turn the floor over to you. In a crash course that I got today with regard to funding of integral care, I understand that many of their issues came as a result of DSRIP ending. They provided a large number of services through the DSRIP funds, and probably more than other local mental health authorities here in Texas. But because they did that, their cliff, when it went away, was a lot higher than the other mental health authorities. So in essence, that was one issue that contributed to this. The other issue that contributed is the fact that the state worked to make up that difference with funding and funding methodologies. They started these methodologies, I think either last year or maybe year before, and based a lot of their utilization rates on FY19. And we know what happened in FY19, FY20. And so it's that sort of decrease that caused these funding abnormalities, in addition to the fact that when the state puts out a new funding formula, there are going to be unintended consequences. There always are. And until they tweak it to alleviate those so that you'll have budget certainty, you're going to have swings. And so it was caught off guard by integral care. And it is something, personally, that I think at this point in time we need to take care of. I think one other point that was made to me in my crash course is that going forward, utilization is a part of those formulas. So if we cut utilization because we don't have the funds, we're actually taking some ability to receive funds from the future because our utilization decreases. Okay? So there are a lot of reasons, and I know there's more details behind this. There's probably more information behind this, and ask you guys if you're interested in that. You can surely get with the board members and maybe Trish. But I think that it's important for us at this point in time to take this, quote, emergency measure to stop this at this point. But I do agree with all of the board members that say we need to plan for the future. Okay? That's my comment. Jeff?
Yeah, so just prior to consideration, I just wanted to reiterate some of the updated amounts. So what we're updating, we're adding $7 million to healthcare delivery, so which would change it to 292,746,806, and we're reducing our contingency reserve to 379,796,303. Just wanted to get that on the record simply.
Okay. So, are you comfortable with your motion, Manager Kitchen?
Yes, with the addition for the language that Dr. Martin had mentioned.
Okay.
And if I may just clarify, so based on some lengthy discussion with Dr. Bell and Mike earlier today in a prep meeting, what you sent as your original idea was split into two parts.
That's right.
Part of it was for the budget, which is just a little short part that you all have in front of you.
Right.
And
Which
that's all
Jeff
we're voting on now.
Just reiterate.
Yes, Jeff just reiterated exactly what that affects in the budget.
Oh, okay.
I believe, and between the two of you, you can certainly correct me, that the portions that needed adjustment, correction, amendment.
Or in the
to your
resolution.
motion Are in the budget resolution.
That's right, that's
Okay,
right.
so we're not voting on that yet.
Okay.
Right. We're not voting on that.
Okay.
And hopefully we have had the discussion for that, so we don't
Yes, I
have
think we
to
have.
reiterate that when we get to
We
that
have.
point.
Yeah.
Actually, if this passes, it makes the CEO recommendation a moot point. There's no need to discuss it.
Right, we weren't. Right. But you were asking about were you asking about the language that Dr. Martin?
Correct. The language that's in the budget resolution, I believe, would need to be adjusted so that you come back to the board. So we
He's just
probably add
adding about,
something into
he's
one of
just
those
talking about that
sentences.
language.
He's talking
that-
about the language
For
that-
the excess piece?
Oh, yeah.
In
It's-
excess of 7 million?
yes.
Yeah.
Excess.
Yes.
Yeah, did you catch the language? Do I need to reiterate it?
Okay.
So it goes
If
in,
it's just the 7 for the budget.
It would go in B.
it goes in B, which is the bottom of the budget resolution part.
Yes, that would be the budget resolution. Okay, we'll deal with that when we get to the budget
Okay,
resolution.
got it.
Okay, sorry.
Now, did you say I need to read this again, or?
No, we have the
Okay, you
budget
got
part of it.
Okay. So, calling the question, all in favor of the amendment, please say aye. Or raise your hand, yeah. Anyone not in favor? And anyone abstaining?
Do you have to abstain for that? Okay, well, we abstained.
Yeah.
Okay.
Yes. Okay. All right, and the motion carries. All right. One down. I'd now like to recognize Manager Valadez for a motion.
I'd like to add to the budget $125,000 to plan, organize, and conduct a bilingual Central Texas Latino and non-English speaking population family support conference. These funds will be used to focus on the healthcare, medical, and
Like,
had it covered, sorry. Do I need to begin again?
Yes, please.
I'd like to move to add to the budget $125,000 to plan, organize, and conduct a bilingual Central Texas Latino and non-English speaking community family support conference. The funds will be used to focus on the healthcare, medical care, mental and behavioral needs of Central Texas Latinos and non-English speaking populations, including but not limited to the mental health and other healthcare disparities facing those populations. The inaugural conference will be held in the fall of 2024 or early 25. The purpose of the conference is to strengthen awareness of Latinos and non-English speaking populations untreated and unaddressed mental health issues and other issues that have contributed to their quality of life.
Okay. I have a motion. Do I have a second? I have a motion from Manager Valadez. I have a second from Manager Kitchen. Any discussion? And here's where you ask your questions with regard to the motion. I'll go around. Start on this side, Manager Kitchen.
I don't have a question, but more of a comment. I appreciate Manager Valadez bringing this. She mentions in part of what she says that this is, she cites the Central Texas African American Family Support Conference, which I'm familiar with. And so, that's a good model.
As a model,
And so just wanted to say thank you for bringing this.
Okay. Manager.
No questions.
No questions. Manager. No questions. Manager Recycling.
Thank you, Manager Valdez. So I have couple questions. Who would take the lead? Who would organize this conference? So
Well,
in your proposal, it doesn't really state what it is. Who would take the lead? Who would organize it? And really, this initiative that you want to bring forth, I understand the motivation behind it and the need, but it just, to me, there's a lot of unanswered questions.
If I'm not mistaken, and Manager Jones is here, I think you were one of the people that was behind creating the Central Texas African American Family Support Conference and Integral Care, or I had been told that you were one of the leaders of that effort, and ultimately Integral Care took the lead, but with the support of Central Health and other agencies, especially in those early years. And so as far as I'm concerned, since this is a new initiative dealing with a specific population, and it is modeling after, I want it to be modeled, I would like for it to be modeled after the very successful African American conference program that I have attended several times. I'd like for Central Health, in tandem with staffs perhaps of other enterprise agencies. So it could be community care with Integral Care. It could be somebody from Sendero, because if you look at the Sendero component for ACA and CHAP, one of their big strengths was the fact that they were one of the few programs, ACA programs, that actually supported and had a good, strong mental health and behavioral health component to their insurance program, which was of benefit to many people when I was in the business of, I guess, enrolling people in ACA. So initially, this is a planning and then to pull it off. So in the planning stages, it would be a group of staff with other people who have worked on this with the alternative, the African American entity. And I know I myself would be very interested in watching it grow, developed. We originally talked about a plan, Manager Giesland and I still have that paper. I'm sorry,
Just
manager.
Mike.
You just
Yeah,
became
not a
manager,
manager.
CEO.
Thank you, though.
But I do
Appreciate it.
have those papers that we originally talked about, and I didn't bring them forward since it had been like 4 years since we'd had this discussion. But I can bring those forward, and it's not tied down. It's purposely, because this is an initiative. It's an idea.
So when I think
Just like the 155 programs that we're looking for.
I understand Manager Valdez.
And as a person committed to health equity, I would think that for an initial program to be begun, that oversight by Central Health would be a welcome thing.
Okay, all right. Go ahead.
If I may, the conference that you are alluding to, I think it's been years in inception. I don't know how
Years.
long.
Yes.
So it takes
Several.
time, and it
No,
takes
that's right.
a lot of another coalition. I know, like, other entities to come and support, to lead the efforts. When I think of a conference, it's mainly more networking.
They're listed here.
So when I'm thinking of something, and the time frame and the parameter, the time frame that you have to accomplish what you want, I don't think it's sufficient. It might be more of a planning phase. If you want something to be successful and to be up to it, it's not even just the planning part, Ms. Valadez, takes time. And even your amount that you're asking for will not probably cover what you want to even the scope of the work that you want to do. I support the initiative, the thought, but to me, there's a lot of there's needs a lot of planning behind the effort that you want to the level that you are desiring. I think this might be an initial step, and maybe if you wanted to revise it, more of a planning for Central Health to take the lead, to plan for the next fiscal year, to build on something that is fruitful, that is beneficial, that has clear objectives, that can benefit the group. So just gathering a group of people without a clear purpose, a clear guideline, with really good programming, good speakers, will not do justice to our to the community that you are alluding to. So I want something to be successful, to be well planned, well organized, that there's a support of other communities. So that's my stand where I am, and I support this, but at this time, I think it's little in the infancy stage, that it requires time and planning for such an event.
I appreciate
so
that.
That's my stance.
I appreciate that, Manager Maram. However, Mustatif, I have put on conferences in this arena at the state level, at the statewide level. We did this within 6 months. I'm not going to do this, but I'm going to be a part of this. And we already have experts, doctors, that have volunteered their services to assist in any way possible. I didn't put any of that information in here because since this is an initial program that I'd like to present to see how, if Central Health supports this, then we can move forward beginning tomorrow with respect to resources. And I don't believe that asking to go above the 125,000 for the first conference is going to happen. I think that that's going to be plenty for the initial conference. It's not going to be 10,000 people present, but I can promise you, in talking to the different communities that I have spoken with in Travis County, just in Travis County, forget those in Central Texas, there has been a lot of support and positive response to this.
Okay.
So I thank you.
Mr. Geeson.
Yes, thank you. A couple of suggestions for consideration, Manager Valadez. One, I think the amount is too low. If we're going to plan, organize, and conduct, meaning actually produce the conference, and so it should be higher. And if I may ask you to consider, too, the timing of it, so say fall of 2024, there's a lot of initiatives that we have outreach already planned and working with our partners for, a lot of it surrounding the opening of the new clinics, but also greater engagement, enrolling more in MAP. And so if we aim for fall of 2024 or even early 2025, we'll have to come back to the board to say, okay, there's some projects here that we're not going to be able to execute on. And there's another, consideration here for looking at later, quite frankly, getting past cold flu and COVID season in early 2025 with the conference. And, I realize that, the risk has gone down somewhat, post-vaccine, but, and again, maybe I'm being hypersensitive about that, but I think Manager Musaidov said it well. There's probably something to be said for, prior to expending any of these funds, we come back to the board, and I just plugged in a date, December 1, because it's relatively quick and early in the fiscal year, to say, here's the scale and the size and the scope of it. And if you're looking for this, the approximate cost will be X dollars. If you're looking for something that's a plenary plus 7 breakouts, that are co-scheduled, it's going to cost this much, and really get a sense about what the true costs are, because I'm really concerned this number is just way too low, and then building into that cost, needing to bring on board the extra bandwidth to do it right, and working with community partners to pull it together. And that includes on the planning as well as the execution piece. So just to sum it up, what I would ask as author of the amendment to consider is that prior to expending any of the funds, that we bring this back to the board for preview with a scale, size, and approximate cost of the conferences by December 1. That way we do this right, because otherwise what you'll get for $125,000 is, considering it's over 65% of our patient population.
Yes.
We could potentially do this on a different scale.
Okay, and that would be,
Yeah.
I
we bring
take
it back to you
your
for
thought.
December, by
I
December
bring it
1.
back to the board before December 1. And if in fact the board does support that, and if they support the business plan that will be presented, in addition to the goals, stated goals and how we hope to carry this off, then would those funds come out of either contingency or the new initiatives, or so that I would know, in fact, where this money would be coming from, if in fact we were able to sell the board on supporting this program?
We could look at some of the outreach funds, some of the initiative funds, but I think the community health initiative funds. But I think but the method of financing is something that the board would also have to determine once you see what the approximate costs are and what kind of conference you want to stage. And just to put it into perspective, and I haven't validated these numbers, but Integral Care spends significantly more on their African American Family Support Conference.
Not initially.
Not initially.
I'm talking about initially.
But now.
Now it's
and also months to plan it properly, line up the
Right.
right speakers, and et cetera.
But thank you very much. I appreciate your comments.
Very quick.
Manager Bell, there's a suggestion that I have, like we're doing it even on a larger scale for other diseases, like for survivorship, for instance. Leveraging an existing conference. I think initially it's like a pilot testing, see what's available there. Maybe you can have a session dedicated to this and building up, so you can do an excellent job, and we want this to be successful. So just an idea, maybe if there is an upcoming conference, so you can try to work with the conference, the planning committee might be helpful.
Thank you. Manager Motwani.
I like the idea a lot. I mean, my initial feelings was, wow, I'd like to be a part of helping workshop this. And I also was getting the sense that the dollar amount was low, but in my mind, I started to think, well, perhaps it could be a seed year. And for me, I prefer iterating. I've also, like many of us here, been involved in conference production in some way, form, or fashion, like substantially. And I could see a pilot conference looking, like something like 30 folks, and see how that works and get some feedback of what was comfortable, what worked, were we engaging, were we getting some good outcomes, and then next year see how do we turn that into 300 folks and go to scale with that. Or, was it this 125 would be for the planning year, and then the following year would actually be production year. 125 is only planning because, in my mind, even though I do know Manager Valadez, that you and so many others can pull things off on a shoestring.
Yeah.
200 folks at $50 a head is already like $100K, and that's not, and so we really want to. For this to be, I think, the quality level of production that all of us are interested in, I do think that number needs to be higher. So then I started to question whether an amendment was necessary or whether there was an existing budget line item that we can, potentially as a board, tap into and, maybe reprioritize in a certain way, whether that was in the outreach section or, again, the CHIF, the community health initiatives or what have you. So I don't know if it was large enough to need to be an amendment or not, but I definitely agree with, that my preference would be that this 125K would be something that we as a board could divert from an existing funding line item without having to do a budget amendment, and we could do a seed planning year this year. And invoking that faucet comment from earlier,
Yes.
if we have a positive planning year, I mean, I see that faucet continuing to turn in the right direction, ongoing, and I could see this being a very, very substantial portion of our institution.
I appreciate your comments because you yourself have seen the gaps that exist in our non-English speaking population. So I appreciate them.
Thank you. Manager Jones?
Yes, I have a lot to say, but I'll try and make it rather quickly because I think we've said a lot.
Yeah.
First of all, I'm supportive of this initiative, this amendment. I think it's a great initiative. It models after what was done with the African American Family Support Conference. I think that when we look at populations, and this goes to what Manager Kitchen was talking about, we need to understand that we're talking about basically populations of color for the most part. And so as we look at this diversity and equity, we have all of this money we're saying here that we have projected. And what I'm hearing from all of us is that we need to utilize these funds to be able to augment these things now. Here are three, mine hopefully will be the next one, initiatives that we can not only do, but that we should proceed to do with and respond to those who said we're holding on to capital or to resources that are not addressing them. I just put that as an editorial comment. Having said that, though, yes, I'm supportive of that. I would also be willing to suggest that perhaps the Black Men's Health Clinic could serve as a facilitator in working with you in developing that. I think that they would be supportive of that effort and serve as a conduit to be able to help facilitate that if indeed this is approved in terms of your first year starting.
I'd love to partner with y'all.
I think that would be a good opportunity to them. So I'm in supportive of that with those clarifications.
And I appreciate your words, and I'll tell you that that is exactly what I was thinking of, because as we speak in general terms for the provision of services for our population, it's very difficult to pin down exactly how the non-English speaking or the African American population or the Middle Eastern population or the Asian population are actually being impacted without speaking in general terms. So something that could be viewed as theirs, targeting them for the benefit of increasing their quality of life, is something that I could I would, and I support it right now. As a matter of fact, I support that right now. I'd hate to see it relegated to, yes, I can come back on December 1st, or we can come back on December 1st with a business plan. But I just, if I have the ability to at least get the support for an initiative like this from the board, I think that goes a long way in telling the community that we're truly interested in resolving and closing disparities gaps.
Thank you very much, Manager Valadez. Manager Martin.
Thank you. I'd like to echo Mr. Giesland and Manager Musaitis' comments that we all support equity and inclusion. I want to make that clear. I don't think, in my opinion, the proposal is not complete. Where did this budget come from? And I would ask that the staff, coordinate a budget and a business plan so we have a real idea as to what we're doing, not just sort of pull a number out of the sky and say, let's do this. I think that's very important because we're responsible for the money. Is this something that would be an ongoing yearly conference?
Yes.
And then that would have to then be calculated into an expended budget as well on a yearly basis.
Presenting a plan that could show how it could become sustainable.
So I just would, if I would ask that Central Health could provide that data for us to look at as to what that ongoing expense would be as well as the initial expense. That's all. Thank you.
Thank you very much, Manager Martin. Well, actually, I was going to go to Jeff or Mike.
Okay.
And have them outline, based on our discussion, is this a structural budget change, or is this something that we put?
I'm not sure because I don't know where bringing something back and then staff can identify funding sources? Are we putting this in the budget resolution to come back? Is this
Okay, so that's what I need, that's what I needed you to say.
Are we fixing the 125,000? Is that the amount we're considering in this amendment?
I get your question.
If so, then we can talk to where that would be.
Manager Valadez, based on your comment, based on the comments that were made with regard to the motion, would you like to make any changes to that motion, or do you still want $125,000 transferred?
The only reason I put $125,000 there initially was for the planning, to tell you the truth, for the planning and the development of what would be necessary to see this get off the ground. But since I have always worked with nonprofits that spend a penny and it looks like they spent 10, you know, it was something that I was figuring I could use as leverage. But it's not me. It's Central Health's dollars. It's our public dollars that I would be still asking for. If I could go to 200,000, I'd say 200,000, just to be in, just to take in the words that I have heard from the other board members and making their suggestions to make this a reality. But what I want to see is that this actually come to fruition, as opposed to next year, you know, well, it doesn't look like we're going to go anywhere. But no, if I have a meets commitment and I have the Black Men's Health Center commitment, Larry says yes, to making sure that this happens, then I would like to move forward with an upgrade to the 200,000 as a motion, if the amendment, or keep it at 125 for planning. And I do have a motion in a second. And if that's going to be what I have to start with, then that's what I have to start with. And I'll start with that.
So what I'm hearing from Manager Valadez is that, because the question to you was, do you want, go ahead, Manager Kitchen.
Let him go first, and then I'll go.
If 100, so I guess the question goes to staff, and if 125,000 can be allocated without a structural change to the budget and without requiring an amendment, my druthers would be that we, as a board, commit to working with staff to finding those 125K and creating a plan for the planning of that. You know, that means which department is it going to sit in, you know, who's going to lead that. I think that those things require a little bit more time than we can probably hash out in this meeting. I think we're all on the record here and we're looking each other in the eyes. We know what we're committing to each other on. I think if we could find those 125K by means of an initiative that overlaps with the outcomes intended of this initiative, that I would very easily support that. And in my eyes, I don't want to commandeer what you're thinking here, but in my eyes, I think one fiscal year of planning sets us up for a second fiscal year of production. And, you know, and so, and then of course, you know, that expense is going to be there that next fiscal year. So, I mean, there, provided that the planning is fruitful, which I'd be leaning toward that. So,
Manager Kitchen.
Yeah, I was just going to add to what Manager Motwani is suggesting, which I think might align with what Manager Valadez is saying, and that is to, you know, so we would change this language to make it clear that 2024, or that we have 1 year of planning. We would say that the staff is going to plan, and that they're going to figure out how to do that, either themselves or maybe the consultants that are, you know, if you have existing consultants or whatever, and that you can use 125,000 to do that planning, and you can find that funding within the budget if you can tell me you think you can find it within the budget. I mean, this is an activity that I think is in our budget because it's an outreach activity, it's a wellness activity.
Yeah, we do. In our attachment B, we have an outreach and education budget line.
How much is that?
It's $1,352,000.
And clearly, the people that I would want to be staff and others on the outside of Central Health would be people who would be included in the population that we're trying to serve, yes. So.
Mr. Giesland, did you have a comment? Jeff answered it. Okay.
But actually, if I may, those dollars, though, they are allocated for other projects. So again, we'll have to come back to you all to say, here's what we will not implement in lieu of pursuing other projects. But that's, as we sit here, it's hard for us to suss that out, what that looks like, so we'll need to come back at a future date.
Manager Marconi?
So my question is, if we were to suggest that there be, for example, that there exist line items in the budget or expense categories, if you will, where we can assume that we can derive 125K, whether it be from outreach, maybe not all from outreach. We don't want to take 10% of that whole budget, but outreach, possibly community health initiatives, possibly
education,
and other line items. Could we cobble together? Do we think we have it in the room to be able to cobble together 125K? And if that's the case, is this action necessary at this moment if we know we're going to get that 125K and likely through the means of other board action move forward on this? Because it's quite consensual, at least among those who've spoken about it.
Manager?
So it may be that the motion is to, for the appropriate staff to develop a business plan, to develop this conference, and then to bring back to the board what that plan is and what that might take.
Okay.
And then we can assume then that for the staff to do that, if they need funding to do that, they could find it within the existing fund. They may not need funding to do that if we have staff on board. I don't know.
Okay. That would be a budget resolution.
Yeah, it would be.
Change, correct?
Do you want that, or do you want to just go ahead and say?
I think so. Just if I could, if we want to, just for clarity, if we're going to consider the motion, we can add the 125,000 to the budget line and just take it from contingency. It would be part of an action the board took. The budget would reflect that increase. That, from my perspective, that would be cleaner.
I think so too. Okay. All right.
Okay.
So the motion stays as it is to move 125,000 from contingency to what line item, Jeff?
Yeah, so it will go to attachment A. Yeah, so it will increase our health care delivery. So I'm in attachment B now, just, excuse me, A, the high level, to 292,871,806, and reduce our contingency reserves to $379,671 and $303. Sorry, $379,671,303.
Okay.
Sorry, my voice is getting hoarse.
Do you accept that as your motion?
Yes, I do, and I also we're memorializing this discussion and the will or intent of the Board of Managers, and with that, I would accept it.
Okay, thank you. Do I need another second? Yes. Wouldn't hurt. Okay. Before I recognize?
I'll second it.
Okay. I have a second from. I have a motion from Manager Valadez. I have a second from Manager Kitchen.
Just for clarification, this amendment is for planning, correct? Okay, that's it. Thank you.
Thank you.
Okay. Call the question. All in favor?
Aye.
Any opposed? Manager Martin, show Manager Martin as opposing. Any abstaining? Motion carries.
Thank you all.
Okay. All right, now we will take motions to approve the budget. No, yours is a resolution. It doesn't structurally change the budget. We're getting to that after we pass the budget, then we're going to go to the budget resolution, okay? I will now take motions to approve the budget. I recognize Manager Motwani for a motion. Yes.
Each one, each paragraph is its own person. Okay.
I move that the board approve the budget items in the Central Health fiscal year 2024 budget that pertain to the University of Texas at Austin.
I recognize Manager Zamora for a second.
Second.
I have a motion from Manager Motwani. I have a second from Manager Zamora. Any discussion? Hearing none. All in favor?
Aye.
Any opposed?
The 35 million.
Show Manager
Is this
Valadez
regarding
for
35 million?
Well, yeah, it's
Okay.
part of the fund. Show Manager Manager Valadez as voting no. Any abstaining? Show Manager Jones as abstaining. The motion carries. I recognize who's left the room. I'll recognize you. Recognize, do you work for the system? You do? Okay. I recognize Manager Motwani for a motion.
I move that the board approve the budget items in the Central Health fiscal year 2024 budget that pertain to the University of Texas system.
I recognize Manager Jones for a second. No? I recognize Manager Zamora for a second. All right, I have a motion from Manager Motwani. I have a second from Manager Zamora. Any discussion?
Just clarification, I apologize. I understand the University of Texas at Austin because I'm assuming that's a medical school, but the University of Texas system, what is that? Is that going to be, what is the system? Are we talking about, David, are we talking?
The system is, the system controls all of the subsidiary
Chancellor
campus. Yes.
And
correct.
all the programs
UT system.
under the University of Texas,
Correct.
period.
Does that answer your question?
Yes, sir.
Okay. Any further discussion? Hearing none, all in favor?
Aye.
Any opposed? Any abstaining? Please show Manager Valadez, Manager Musaitif, and Manager Jones as abstaining.
Just for the record, I'm abstaining because of school and work conflict.
Right.
Okay. Did you want to?
I'm abstaining because I'm tired. I'm abstaining because I had a contract with him and I'm no longer doing it, but it's still within this time frame. So.
Okay, thank you. Motion carries. I recognize Manager Jones for a motion.
I move that the board approve the budget item in the Central Health fiscal year 2024 budget that pertains to integral care and project access.
I recognize Manager Motwani for a second. I have a motion from Manager Jones. I have a second from Manager Motwani. Any further discussion? Hearing none, all in favor?
Aye.
Aye. Any opposed? Any abstaining? I have an abstention from Manager Kitchen. I have an abstention from Manager Zamora. Thank you, motion carries. I recognize Manager Valadez for a motion.
I move that the board approve the budget items in the Central Health fiscal year 2024 budget that pertain to Sendero Health Plans, Inc.
I recognize Manager Martin for a second. I have a motion from Manager Valadez. I have a second from Manager Martin. Any further discussion? Hearing none, all in favor?
Aye.
Any opposed? Any abstaining? Did you want to abstain?
I traditionally haven't abstained, and if
Okay.
so, I'm not compensated by either of the boards, and I'm driven by the mission that's shared between the two.
Well, I agree with the compensation. All right, so motion carries.
No duality.
I recognize Manager Martin for a motion.
I move that the board approve the Central Health fiscal year 2024 budget as amended for all items other than the items related to the University of Texas at Austin, the University of Texas System, Integral Care, Project Access, People's Community Clinic, and Sendero Health Plans.
I recognize Manager Kitchen for a second. I have a motion from Manager Martin. I have a second from Manager Kitchen. Any further discussion? Manager Martin.
As best known to me, and I was one of the founding board members of Project Access, Project Access is no longer functioning.
Is that correct?
That's what I was told by Travis County Medical Society.
People said.
All right, so.
No. I can tell you we're not going back.
Okay. That being the case, it really doesn't matter because it got called out and it's being put back in. So it's in one place or the other to the extent it has funding. And I was going to say the same thing about Peoples because I took the Peoples motion off because you fell off the board and it somehow ended up in this version. I took it out of the script, but somehow it's in the motions. So it doesn't matter.
Okay.
It's in general health care anyway. Mike just told me. So I think you're fine regardless.
Sounds great. All right. Hearing no further discussion, all in favor? Any opposed? Any abstaining? Manager Valadez abstaining? Show Manager Valadez as abstaining. The motion carries. All right. We have a budget, members. Now we're going to take up the approval of the budget resolution. We will approve the resolution that was provided to the board via email. You have a hard copy at your desk. After the approval of this document, I will recognize members who have submitted revision proposals to outline their proposals in the form of a motion. Upon a second, I will open discussion for any questions and then call for a vote. I recognize Manager Musaite for a motion to approve the budget resolution as distributed.
I move that the board approve the budget resolution that was provided to the board via email.
I recognize Manager Valadez for a second. I have a motion from Manager Musaite and I have a second from Manager Valadez. Any further discussion? Hearing Manager Kitchen?
Don't we have to vote on the amendments?
We're going to amend it after we approve it.
Oh, okay.
Resolution's gonna go first.
That's the way they told me to do it. All right. Okay. Any further discussion? Hearing none, all in favor?
Aye.
Any opposed? Any abstaining? Motion carries unanimously. All right. I will ask each manager to outline their amendment to the budget resolution in the form of a motion. Upon a second, I will open discussion for an explanation and then call for a vote. I recognize Manager Jones for a motion.
I move the board amend the Central Health FY 2024 budget resolution by inserting the following language where appropriate and renumbering accordingly. Provide funding to community care for a total annual not to exceed of $500,000 to support increased operations at the Black Men's Health Clinic. Okay, no problem. I move that the board amends the Central Health FY 2024 budget resolution by inserting the following language where appropriate and renumbering accordingly. Provide funding to community care for a total not to exceed an amount of $500,000 to support increased operations at the Men's Health Clinic. Black Men's Health Clinic, did I say? Thank you.
Okay, I have a motion. Do I have a second? I have a motion from Manager Jones. I have a second from Manager Valadez. Any further discussion? Manager Musaidi.
Thank you. Manager Jones, I have a question, comment in terms of the no-show rate, which is about like 40%. So is there a plan to address the no-show rate?
Yes, I'm not sure exactly about those numbers, but I'll take your word. The no-show rate has been, as I mentioned at our last meeting, is the challenge of being able to get men of color particularly, who are working, those who are not working, to be able to show up on a particular date at a particular time, given certain criteria. And so by enhancing additional dollars from Central Health to community care to be able to do this, we will have more days available for them to be able to be seen and to be able to be served at those clinics.
So why are they even scheduled on the calendar if they're not able to make it?
Well, they're scheduled because they anticipate being there. But life happens, and as a result, they are not able to make it for whatever reason.
So has there been any kind of initiatives or of reaching out, calling the patients, a survey, like why you have not been able to be seen? You missed your appointment?
Well, a couple of things. One is there are outreach efforts out there to, one, build up the capacity. Once those capacity are built up, then they do follow up with them to see if they can do it. The question is, the program has only been funded for a year now, and it hasn't been funded the whole year. And so they're getting there, but in order to sustain successful operations, they really need this foundation funding to be able to build upon that.
I understand. I'm not questioning. So I know that's something that we both talk about. How do we close the gap and address the health disparities? So there's two pools of patients. There's the existing patients who need like follow-up. How are those managed different than other patients that you're trying to reach up to engage into your clinic? So is there a plan to really keep them continue their care for those patients who are already existing, who have other comorbidities? I think they've highlighted hypertension as one. How do we manage them? Are they coming? So is there efforts? I know there's a good outreach. So I just wanted to know, we want to close that gap.
Yeah. Well, yes, there is an effort underway currently to maintain the caseload that they have, build upon it, utilizing them to help build that. Additionally, is the ability to make sure that any new and additional clients that are coming in are being able to be seen timely, to be able to be managed timely, and to make sure that they are being seen by the appropriate staff. Now, remind you, this is just the beginning. This is a first effort to try and begin to get resources built there. This initiative is something that I think will go a long way to addressing those things that we've been talking around here, and it's particularly an equity effort. So to answer your question, yes, there are programs currently underway to manage those that they have. But many of those are the brothers, the cousins, the nephews, or others who cannot get in because they're only there 1 day a week. And if the doctor's not there, then they have to reschedule. If their provider's not there, they have to go someplace else. So yes, the answer to that is yes.
So I hope, if this motion passes, that by next year that the numbers are different, that we're able to see more patients are continuing their care, so there's efforts, the no-show rate is reduced significantly. So that is my hope and anticipation.
Well, I would agree with you, but I think that if we look at the no-show rate of other patients in other facilities there, this may be a little higher. It's new. It's been around, community care has been around a while. So the goal is to be able to get this population up to where the other ones are, recognizing that the other ones are not perfect either.
Thank you.
Any further questions? Manager Martin?
Yeah, I just wanted to thank you. I wanted to have something clarified to me because last meeting we had, our COO told us that there are ongoing rolling funds for community outreach, I believe, and that $286,000 will continue on a year-to-year basis for community outreach. And I guess want clarity, is this extra funding to fund for subsidization of physicians if they go there and don't see patients as we discussed last time, or is this just a lump sum to continue more outreach?
No, this is money to be able to hire clinicians.
Just physicians?
Clinicians,
Okay.
Maybe nurse practitioners and others to provide services there.
Okay.
Currently, they're not being provided with the funding that currently goes there. It's outreach.
Okay, thank you. So because last time we discussed it, this would be a thing to try for the year to, because I agree with you, you have to extend the hours these people work. They have, things happen, as you say. But that this money essentially go to subsidize essentially community care for the physicians go there. They maybe see 2 people instead of 20, and that we'd still subsidize that. Is that what the money is for?
Exactly.
Okay, thank you very much.
Thank you. Any further questions? Hearing none, all in favor?
Aye.
Any opposed? Any abstaining? Motion carries unanimously.
Thank you.
I recognize Manager Musaitu for a motion.
Thank you. I move that the board amend the Central Health fiscal year 2024 budget resolution by inserting the following language where appropriate and numbering accordingly. Ensure cancer screening, diagnosis, and treatment services are developed for staging of priorities within the healthcare equity plan, building on cancer services efforts supported by the Central Health fiscal year 2023 budget resolution.
Do I have a second? Manager Valadez. I have a motion by Manager Musaitu. I have a second by Manager Valadez. Any further discussion? Hearing none. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. I recognize Manager Kitchen for a motion.
Amend the fiscal year 2024, I move to amend the fiscal year 2024 budget resolution by inserting the following language where appropriate and renumbering accordingly. Enhance behavioral health and substance use treatment integration into comprehensive care models, including health-related support for diversion or deflection services in conjunction with other local efforts. And that was in it previously, so now I'm adding. In addition, increase the funding amount in Integral Care's fiscal year 2023 service amendment by $7 million for program services that intersect and align with both Central Health's and Integral Care's missions to enhance services for low-income residents and improve health equity. The Central Health CEO will determine appropriate program services in collaboration with the Integral Care CEO and report to the Board of Managers by October 4th. The programs identified and funded as advancing the missions of both organizations. Central Health will work with Integral Care to include programs and services such as the following: crisis hotline services, health equity through CCBHC project, which prioritizes expanded access to integrated system of care to address population health disparities, continued mobile crisis outreach teams, that's MCOT, and system of care services, mood treatment center services, parens, intensive outpatient services to individuals with bipolar disorder, close parens, expanded community mental health center services, parens, to address continued growth of population and community needs. The last bullet is wellness services, parens, nutrition, and tobacco cessation for individuals with SMI. B, that was all A. B, considering recent fiscal challenges facing Integral Care, Central Health staff will regularly coordinate with Integral Care to develop approaches to avoid disruptions or delays in the mental health and behavioral health services for the low-income population in Travis County. Central Health staff will take steps to avoid as expeditiously as possible such service disruptions to eligible low-income persons and may utilize additional contingency reserves to do so, provided, however, that the CEO will report back to the board before funding such additional services. Central Health staff will report to the Board of Managers Budget Committee on a regular basis any allocation of reserves for this purpose, with the first report occurring at the next Budget Committee meeting. This section is intended to take effect if The additional funding specified in paragraph B subsection 2A, which is the 7 million, is insufficient to avoid disruptions or delays in services.
Thank you. Do I have a second? Manager Valdez. I have a motion from Manager Kitchen. I have a second from Manager Valdez. Any further discussion? And please, members, remember we discussed this. All right, so any further discussion? Hearing none.
I want to thank you all for architecting this.
Thank you. Hearing none. All in favor?
Aye.
Any opposed? And any abstaining? I have 2 abstentions, Manager Zamora and Manager Kitchen.
Even though she's the maker of the motion.
It doesn't matter, yeah. Okay, the motion carries. And members, thank you. I'm going to ask the staff to huddle and make these changes to the budget resolutions that we've approved and present a copy to us to sign before leaving this evening. We will need each of you to sign the budget resolution prior to its presentation to the Travis County Commissioners on Tuesday, September 19th. I will table agenda item 2 until the staff return with a completed final budget resolution. And for the sake of time management, I will continue on with the rest of our agenda and we'll call up agenda 2 item when the final budget resolution is complete. Okay. Agenda item number 3, take appropriate action on Central Health's proposed fiscal year, tax year 2023 tax rates. A, total maintenance and operation tax rate, which is a roll call vote. B, total debt service tax rate, which is a roll call vote. And C, total ad valorem tax rate, which is a roll call vote. Jeff Knodel and Kim Johnson will be presenting.
Apologies, Manager Bell. Remember, you voted on the budget resolution, and then you voted on the amendments to the budget resolution. Did you want to vote on the budget resolution as amended?
You told me that I shouldn't vote on that until I bring the agenda
That's right.
item
I
back
apologize.
up.
That's why that's why Mike left. My apologies.
All right. All right. Jeff?
Okay, yeah, thank you. Just real quickly, this is for consideration and adoption of the FY 2024 Central Health property or ad valorem tax rate. Total rate would be 10.0692 cents. The M&O portion of that, so the two pieces of it, M&O is the largest portion. Is 9.6071 cents. Oh, sorry. The M&O portion of that is 9.6071 cents, and that represents a 6.5% increase over the no new revenue rate. And then the debt service rate would be 0.4621 cents, and this is all per $100 evaluation. Thank you, Chair.
Thank you, Mr. Knodel. All right. Members, as a reminder, this item is the consideration of the revised tax rate for tax year 2023, which funds the Central Health fiscal year 2024 budget we took up previously. This is the tax rate only and does not affect the homestead tax exemptions for residents over the age of 65 and residents who are disabled or veterans, which have already been approved by the Travis County Commissioners Court. Each subpart of this item will require a roll call vote. For this roll call vote, Ms. Giannis will call the name of each board member in attendance. Each board member must indicate whether they are voting yes, no, abstaining from a vote on the tax rate. Ms. Giannis will confirm your vote before moving on to the next member to ensure that we have an accurate vote tally. Members, when I recognize you for a motion, please be sure to accurately read each of the motions. I recognize Manager Musaitif for a motion.
A, for the maintenance and operations tax rate, I move that the property tax rate be increased by the adoption of a tax rate of 0.096071, which is effectively a 6.5% increase in the tax rate.
Thank you. I recognize Manager Brinson for a second.
I second.
I have a motion from Manager Musaitis. I have a second from Manager Brinson. Any further discussion? Hearing none, all in favor? Excuse me. Hearing none, Ms. Brianna Yanis will now assist me in taking a roll call vote.
Okay, I'm just gonna go from left to right. So Manager Ann Kitchen,
Yes.
Manager Ann Kitchen votes yes. Manager or Secretary Cynthia Valadez.
I'm gonna tell you, I know people that even though $56 doesn't sound like much, it's a lot. And so I support this, but I support poor people's concerns over increased tax rates. Is there an ability to abstain?
Yes.
Abstain.
Secretary Cynthia Valadez abstains. Manager Guadalupe Zamora.
Yes.
Manager Guadalupe Zamora votes yes. Vice Chair Cynthia Brinson.
Yes.
Vice Chair Cynthia Brinson votes yes. Chair Charles Bell.
Yes.
Chair Charles Bell votes yes. Treasurer Maram Musaitif.
Yes.
Treasurer Maram Musaitif votes yes. Manager Amit Matwani.
Yes.
Manager Amit Matwani votes yes. Manager Shannon Jones.
Yes.
Manager Shannon Jones votes yes. And Manager Manuel Martin.
Yes.
Manager Manuel Martin votes yes.
Thank you, Ms. Yanis. And the motion carries. Okay, B, I recognize Manager Kitchen for a motion.
I move for the debt service tax rate, I move that the property tax be increased by the adoption of a tax rate of 0.004621, which is effectively a 122% increase in the tax rate.
I recognize Manager Valadez for a second.
Second.
I have a motion by Manager Kitchen and I have a second by Manager Valadez. Any further discussion? Hearing none, Ms. Brianna Yanis will now assist me in taking a roll call vote.
Manager Ann Kitchen.
Yes.
Manager Ann Kitchen votes yes. Secretary Cynthia Valadez.
Yes.
Secretary Cynthia Valadez votes yes. Manager Guadalupe Zamora.
Yes.
Manager Guadalupe Zamora votes yes. Vice Chair Cynthia Brinson.
Yes.
Vice Chair Cynthia Brinson votes yes. Chair Charles Bell.
Yes.
Chair Charles Bell votes yes. Treasurer Maram Musaitif.
Yes.
Treasurer Maram Musaitif votes yes. Manager Amit Matwani.
Yes.
Manager Amit Matwani votes yes. Manager Shannon Jones.
Yes.
Manager Shannon Jones votes yes. And Manager Manuel Martin.
Yes.
Manager Manuel Martin votes yes.
Thank you, Ms. Yanis. The motion carries. Item C, I recognize Manager Matwani for a motion.
For the total ad valorem tax rate, which is the sum of the maintenance and operations tax rate and debt service tax rate, I move that the property tax rate be increased by the adoption of a tax rate of 0.100692, which is effectively a 2% increase in the tax rate.
Thank you. I recognize Manager Zamora for a second. I have a motion from Manager Matwani. I have a second from Manager Zamora. Any further discussion? Hearing none, Ms. Yanis will now assist me in taking a roll call vote.
Manager Ann Kitchen.
Yes.
Manager Ann Kitchen votes yes. Secretary Cynthia Valadez.
Abstain.
Secretary Cynthia Valadez abstains. Manager Guadalupe Zamora.
Yes.
Manager Guadalupe Zamora votes yes. Vice Chair Cynthia Brinson.
Yes.
Vice Chair Cynthia Brinson votes yes. Chair Charles Bell.
Yes.
Chair Charles Bell votes yes. Treasurer Maramu Saitov.
Yes.
Treasurer Maramu Saitov votes yes. Manager Amit Mawani.
Yes.
Manager Amit Mawani votes yes. Manager Shannon Jones.
Abstain.
Manager Shannon Jones abstains. And Manager Emmanuel Martin.
Yes.
Manager Emmanuel Martin votes yes.
Thank you, Ms. Jonas, and the motion carries. Members, thank you. We will each need to sign the tax resolution that was provided in your backup materials. Brianna Yanis will be reaching out to you to find out the best way to obtain your signature. The tax resolution summarizing these votes will be presented along with the budget to the Travis County Commissioners Court on Tuesday, September 19th, 2023. Okay, we will go on to agenda item number 4. Oh, I'm sorry.
Very quickly, Dr.
Please,
Bell.
quick.
Is it possible for us to just print out those signature pages right now so you can get us while we're still here?
Brianna, is there a way we could get the signatures for the tax rate
Just the
resolution,
signature
or
page?
is there,
I'm gonna have to adjust it.
you're gonna have to adjust
We,
for the abstention?
yeah,
Okay, that's fine.
you'll have it within the next 10, 15 minutes.
Hopefully it's hopefully we'll have it all. Let's see.
Good, yeah. Okay, agenda item number 4, receive an update on the board-adopted healthcare equity implementation plan, including the development of the performance tracking plan and the key performance indicators, KPIs. And I have presenting Anise Kendall and Monica Crowley, along with Dr. Abney Sharma and Danielle Srinivasan from Guidehouse. Welcome, and we are sorry we have kept you this long, but this was probably the worst board meeting that you could have presented after our budget. So.
Okay. Good evening, managers. Recognizing that it is late, we do appreciate the opportunity to present an update on the development of the performance tracking plan, which includes KPIs, continuous monitoring and evaluation of the board-adopted healthcare equity implementation plan. Developing a robust performance tracking plan is critical to Central Health being able to measure progress towards achieving a more equitable healthcare system, as well as ensuring successful execution of the healthcare equity implementation plan. Subject matter experts are continuing to work on the identification of cross-cutting metrics across a number of categories. In addition to reviewing categories, Dr. Abhi Sharma from Guidehouse and Danielle Srinivasan, who will be joining virtually, will present a high-level performance tracking plan and the guiding principles to KPI selection focused on building healthcare equity. Thank you, and I'm going to now pass the presentation to Dr. Sharma and Danielle from Guidehouse.
Thank you, Anissa. And I know it's late, so I'll try to speed through and just focus on the highlights. So for today, we wanted to focus on 2 things. The first one was give a progress update on where we are in the larger scheme of things. And secondly, we wanted to talk a little bit about the process that we've leveraged to identify KPIs that would then be used to track the performance of initiatives that will be implemented. Next slide, please. So as you can see, we started 2 years ago. The first order of business was to identify needs in the community, and that served as the foundation for what came next. And what came next was, what does Central Health focus on? Now, when we started thinking about the what, we concluded our analyses with a strategic plan that clearly identified the North Star for Central Health, which was improving access to the population that Central Health cares for in Travis County. Now, what came after the what was, how do we actually do that? And that was when we began the operational and financial planning part of our engagement. Now, out of this assessment came out 2 products. The first one was a list of initiatives that would be required to meet community needs. And these were sequenced in an operational roadmap. That operational roadmap included how long each of the initiative would go on and how it would connect with the other initiatives that were identified during the assessment process. It also resulted in a financial sustainability plan, which was essentially the amount of money that would be required to stand up and sustain the initiatives that were identified over a 7-period window. Now, as we think about executing on those initiatives, we need to hold direct care providers as and when they enter the network, as well as our partners accountable. And the way to do that is to identify key performance indicators. Now, we are at a point where we are diving into the details of our initiatives and creating business architecture maps for them, but we are also simultaneously identifying KPIs that we will use to hold our partners accountable, as well as central health providers accountable to what the initiatives are expected to yield. Next slide, please. So this is the macro view of what we have been able to achieve over the last 2 years. Like I mentioned, we started with identifying needs. Now, once we identified those needs, we identified projects that would address those needs, and those projects, which were around 115 number, were then stacked as initiatives. Now, this was because we wanted to transition from the abstract idea of projects to the tactical idea of initiatives that then formed the basis of the operational roadmap. Now, once we had the operational roadmap, we started looking at the capabilities that would be required to execute those initiatives from a process point of view, from a capital expenditure point of view, from the personnel point of view, IT point of view, and that drove the creation of a financial model. Now, we are at a point where we are closing in on implementation. Some of the initiatives that had been going on are already in progress, and we right now, like I mentioned, are identifying KPIs that would allow us to track performance and adoption of initiatives moving forward. Next slide, please. Now, we've seen this multiple times. This is a diagrammatic view of what a efficient healthcare safety net system looks like. The two things that need to be highlighted here are the fact that all of these cogs represent different service types, and they need to work in cohesion with one another for the system to work. And in order to support that, you need a core of navigation services and structural components like buildings and IT to make sure that the cogs function the way they're supposed to. Now, when we started thinking about the initiatives and drafting the capabilities and timelines for those initiatives, we also started to think about the metrics that would be used to track those initiatives. And what you see on the right side of the screen are these 9 domains that will be used to identify metrics. And again, I want to focus on the process now. We are still at a point where we are identifying metrics in consultation with experts within these areas. But the process is that we will have metrics for these 9 domains. Now, the thing that is not explicitly stated here is equity. And the reason it's not here is because all of these measures would then be looked at from an equity point of view. Now, what does that mean? It means that for these metrics, we would look at how these metrics vary across demographic groups, across groups that represent different socioeconomic groups within our community, as well as the financial and educational aspect of how those things are actually impacting access to care and other metrics. Now, if I go one by one through these domains, the first and most important metric here is access to care. It is pertinent that we track access and how access is impacted by the initiatives we are executing. The second is quality metrics. Now, this is quality of care. And just to give you an example, if we are looking at a big set of diabetics, glycemic control is one of those quality metrics. So we want to track quality metrics to make sure that our initiatives are also having a positive impact on quality of care. The next one is care coordination. What's on the left side is a system of care. And as you can see, the different cogs might reside in different systems because we are dependent on partners for providing some of this care. Now, what that mandates is a special focus on care coordination. We need to make sure that transitions of care are happening appropriately. We need to make sure that data and medical documentation is being shared appropriately and readily between provider systems and facilities, and for that, care coordination metrics are critical for us to track. The next one is patient experience. So we are using patient experience as a guide to understand what patients report when they see a physician or a provider. Now, patient experience metrics are best tracked if they are reported by the patient themselves, and that is going to be our focus here. The next is volume. So as the population within Travis County changes, as more people get enrolled, we want to make sure that we track the impact of our initiatives on the percentage of total enrolled patients who are accessing our service and how that tracks over a period of time. The next one is labor. So from the labor point of view, we are looking at staffing benchmarks, physician to patient ratios, physician to nursing ratios, to make sure that the basic infrastructure and personnel who are required to provide care to our patients are adequately available and are trained to make sure that the quality of care and the standards of care are also maintained. The next one is financial measures. So you were just debating the budget, and it's extremely important for us to make sure that, again, our fiscal capacity balances the financial need that underlies these initiatives. And one of the key things that we want to track here is operational expenses. As Central Health moves towards a direct care model, tracking how operational expenses change over time is going to be critical, because that is going to allow us to gauge where money is being spent efficiently and how that money can ensure that our initiatives are sustained over a long period of time. After that, we are also looking at IT metrics. So think about EMR adoption, medical reconciliation. We want to make sure that the IT backbone that is required for the system to function is present and is effective to, again, empower physicians to do what they need to do, but also to make sure that patients are also getting the care they need through the adequate sharing of information across the system. The last domain here is throughput metrics. So specifically for inpatient and ED care, we will be recommending throughput metrics just to make sure that wait times and times that are spent within EDs, as well as length of stays within an inpatient setting, are tracking with national standards and are also improving as these initiatives become more mature over time. Next slide, please. So as we think about these 9 domains, like I mentioned, we are going to put the health equity lens on each of these. Now, we want to make sure that social determinants of health are being included as we think about how these metrics would be tracked. We want to pay special attention to clinical quality measures and how those vary across racial, socioeconomic, and cultural cohorts. And we are going to make sure that we also have benchmarks based on our experience with some systems that are similar to Central Health that can then be used to track how closely our measures are progressing over a period of time. Now, if you think about health equity measures, effective health equity measures have 3 characteristics. The first one is they are individualized. You need to be able to track those measures either at the individual patient's level or at the individual provider's level. The second one is proximity to health outcomes. We want to make sure that we track those measures that are directly impacting health outcomes. As an example, inpatient stays and length of stay is a measure that is directly impacted. So tracking how length of stay varies across different racial cohorts, cultural cohorts is valuable, but if we think about mortality rate, it is not directly correlated to a health outcome because there are a lot of factors that are going to impact mortality rates within communities. And the third thing is they need to be measurable and adoptable. So we want to make sure that we at the end have KPIs that our partners can also track, because we need to make sure that what we are asking our partners to do is actually within their reach. Next slide, please. Now, I've discussed all of these, but just to bring us back to some of the guiding principles that are being used to identify these measures. The first one is we need to make sure that we are thinking about the system of care and identifying measures that allow us to gauge how well the system of care as a whole is functioning. This does not mean that we are not going to look at measures at the individual provider level. It just means that we will pay special attention to measures that show the cohesiveness of our system of care. We want to make sure that the list of measures is comprehensive, so right from screening through to post-acute care. We want to make sure that all of those measures are appropriately represented, because again, we want to track how our initiatives are impacting every single step in the continuum of care and how the patient will be experiencing the system in a new, better way moving forward. We want to make sure that patient experience is front and center. We are doing all of this for the patients that we serve, and making sure that patient experience measures are tracked appropriately and vitally across our network of providers is another guiding principle, the principle that we've used. Now, these measures have not been a figment of our imagination. We've used databases that our provider systems and health plans use in the country. So CMS is one of the most widely used data set for KPIs. We're also using HRSA resources as well as other resources that we have gained access to through our work with other systems like Central Health. These measures need to be broadly addressable. So again, this is going back to the point of we need to identify measures that can actually be influenced by healthcare functions and not measures that are more global in nature. And the last one is equity. So like I mentioned, we've put additional attention to ensure that we put the equity lens on each of our measures. And the way we are doing that is, again, looking at those measures and how they vary by the different socioeconomic, cultural, and racial cohorts that we want to track these for. Next slide, please. So, like I mentioned, we have created a framework and a process for us to identify these KPIs, and we are continuing collaboration and discussion with Central Health experts to identify which of these measures meet our guiding principles, our overarching goals. And we are going to continue to do that with the goal of coming back to the Board of Managers with a list of KPIs before October's second meeting that has been scheduled for the board to meet. That was it. Any question?
Yes. Managers, remember, it's 9:23.
Very short. And we can take it offline. So my question is about provider experience metrics, whether those will be included. Second question, I think I heard you say that metrics would be stratified by race, ethnicity, that sort of thing. And then third, we can take offline. I'll be really interested in seeing what care coordination measures you have. Yep. You can answer all that offline.
Yes, so
if you want me to take it offline, I'll be happy to.
if you can get with her.
Just get with
Yeah,
me.
absolutely.
Yeah.
That would be great. I appreciate that, Dr. Sharma. Any other questions? Manager Jones.
Yeah, offline also, I'd like to be able to quantify dollar-wise what we're saying here, because one of the challenges I'm hearing is, what is this costing us? And so I'd like to be able to say project by project, you know, and we can do it offline. But I think that's important because we just went through a budget process in which we found ourselves challenged to be able to find funding to do things, and yet we have initiatives underway. So are those initiatives incorporated in that as well? If so, so anyway, I'll do it offline.
Yeah. And as far as I know, they are incorporated in our budget. So, and there is a listing of the amounts for the initiatives that we've approved. We can get that offline, but we can get that to you and go over that.
Okay.
Okay? Extremely.
And we'll talk offline also.
Thank you.
Who is going to, what lens is going to be used? Whose lens are we using to evaluate whether or not services were appropriate for the diagnosis of the patient and services that they received or needed to in order to transition out back home or into another setting? I just wanted to know, is it a medical person? Is it going to be somebody of the same experiences of the patient? That kind of thing. So, thank you.
Yeah, it'll be based on clinical appropriateness, so medical professionals would be best suited to evaluate those objectively.
Okay, thank you so much. Appreciate it. Thank you, Dr. Shaw.
Thank you.
Appreciate it.
Thanks.
And look forward to seeing you again. Okay, agenda item number 5. Agenda item number 5, receive and discuss initial update on cancer care, focusing on contracted services and future updates. I'm told that this is going to be really short, or if you would like for me to postpone it until October, I can.
We can make it as long as you like, Dr. Bell.
We can make it as short as I like. That's the word.
We can make this very quick.
Okay.
All right. Good evening, Board of Managers. John and I are going to jointly present on current central health oncology services and initiatives. We're going to touch on prevention, screening, and treatment. And as a gentle reminder, this was an FY23 budget resolution. Oh, I think it's my turn. Sorry, I missed my cue. Good evening, managers. I think we're going to break this effort down into a couple of categories. Really only 2 slides here. So we're going to spend time talking about prevention and screening. Then we're going to spend time talking about diagnostics and treatment, acknowledging that there's absolutely overlap between those categories, but just wanted to try to provide some organizing framework here. And again, this is focused on current services and current initiatives. We will have lots of discussion going forward as part of the Guidehouse-led work and the service delivery strategic plan on a lot of different service lines, but certainly including oncology as well. Starting off with breast cancer, just to help orient the board to current services and initiatives. Our breast cancer screening services are primarily provided through in-house mammography at community care. We have mammography units at North Central as well as Southeast Health and Wellness. And one of our current initiatives is to upgrade that equipment going into FY24 to make sure we have the latest technology, which is 3D mammograms available to our patients. We have additional access points through Ascension and their hospitals, through UT Health Austin at the medical school, and also through a network agreement with Austin Radiological Associates. And you all may recall that this board provided some capital funding to reinstate the Big Pink Bus. That's the same Big Pink Bus that was previously operated by Ascension. It was discontinued for a number of years, but we're happy to see that back in service. Part of that funding, and we funded both capital and ongoing services, but part of that funding helps direct and focus the Big Pink Bus's outreach efforts in eastern Travis County, where we know we have patients that need to be reached. Since that project was brought back online last year, more than 685 women have received screenings since that started up again. And in total, just to give you a sense of scale, we provide approximately 4,000 breast cancer screenings every year to our patients. Al?
Thank you. As related to colorectal screening, Central Health has been partnering with Cancer Prevention Research Institute of Texas, Dell Medical School, and our partner FQHCs. And over the past 4 to 5 years, gradually increasing that colorectal screening. Really starting out with the FIT tests. I touched on it last week, but these are tests that are sent out to patients' home where they can test at home, send those tests back in, and they can be done in clinic, both in primary care environments and in specialty environments. Those tests can basically show if there's a positive finding, if there's blood in the stool, the providers can then look at the symptomology based on the risk profile and then send patients for colonoscopies. Colonoscopies under the Omnibus and Master Services Agreement are still the responsibility of Ascension. So the majority of those, or those diagnostics, are done within the Ascension environment. And then we've also contracted with providers both in North Austin and South Austin to increase access for colonoscopies. As you all know, in approximately 26 days and some odd hours, we're opening our specialty clinic. And so can start the diagnostic or the initiation of diagnosis there, and are working with UT in their ASC to then utilize that environment for additional colonoscopies.
Okay, next is cervical cancer screening. So the U.S. Preventative Services Task Force recommends cervical cancer screenings for the general population every 3 years. It certainly gets a lot more complex as you consider different individuals' health risks and history. But primarily these screenings are provided through our primary care providers, with the vast majority of those happening through our 3 FQHC partners, and also our gynecology services. Several years back, we added additional gynecology services or complex gynecology services through an IPU with the medical school that also includes surgical services. And then in recent years, we've been working with those FQHC partners to also help enable them to perform women's health procedures in ASCs as well. So that's still an ongoing effort, but we're happy that People's Community Clinic really led the way there in terms of our work with the FQHCs here in the past year, and those procedures have started here recently.
As related to lung cancer screening, again, we've partnered with CPRIT for individuals who have a 20-pack year history of smoking. So if you smoke 1 pack a day for 20 years, that's a 20-pack year history. 2 packs a day for 10 years, 20-pack year history. Individuals who qualify or who have quit within 15 years need a low-dose CT. And so CPRIT, UT, and our FQHCs have partners to gain people access to that low-dose CT and as early a diagnosis as possible. In addition, we help fund medications for cessation of smoking, peer support, and counseling.
Skin cancer screenings are largely similar to the cervical cancer screenings I mentioned earlier. These are routinely provided by our primary care providers and also our network dermatologists. And that's really based on criteria that considers the individual history of the patient and their family members. It is the most common type of cancer in the United States, but fortunately the majority of those are not of serious medical concern. About 1% of those are melanomas, and there are serious forms of skin cancer that certainly necessitates the screening component of that. Most of the primary care screenings, again, are occurring through our FQHC partners, and then dermatology access is provided from a clinic perspective largely through community care and through our network agreement with Austin Regional Clinic. And I think I have the last one here too, sorry. So just a quick note about pay for performance. So increasing the rates of preventable or screenable cancers in our population has really been a priority for Central Health for a number of years. It was also a priority in the Community Care Collaborative and in the DSRIP programs. So we've had pay-for-performance incentives, metrics that we follow, and financial incentives that we provide our providers to increase those screening rates every year. The DSRIP projects have since ended, but we have transitioned many of those pay-for-performance type structures into their base services agreement. So it's another good example of something that we were able to test and learn from in the DSRIP environment, and then make sustainable in our service agreements going forward. Next slide, please.
Thanks. Diagnostics for breast cancer screening are the primary responsibility of Ascension. At the same time, as we stated before, we've increased access for colorectal cancer screening both in North Austin and in South Austin. We're working with UT for access and utilization of their ASC for diagnostic purposes. And we are working with Austin Radiologic Associates as far as increasing access for breast diagnostics, as far as diagnostic mammograms, ultrasound, and biopsy. As far as medical and surgical oncology, again, this falls under the Ascension responsibility under those same agreements that I previously mentioned. And then we are working with other partners in town. The medical and surgical oncology services, as I said before, fall under Ascension, and we're working on those contracts.
So I'll speak to chemotherapy and radiation oncology, radiation treatment services, just briefly. So very similar to medical and surgical oncology, chemotherapy is a responsibility of Ascension in our Omnibus Services Agreement and the Master Services Agreement. They today provide almost all of the chemotherapy for our patients at the Seton Infusion Center. This is another area like medical and surgical oncology that we are continuing to work with partners in the community and evaluate other opportunities to expand access points for our patients and different treatment options. Specifically, you all are aware of the recent announcements from University of Texas and the fact that MD Anderson is planned to build a campus here. Those are developments that we're watching closely, and we'll have more conversation on that, I think, in future meetings. For radiation oncology, this has been a focus of our cancer care work here over the past year or two. This is a little bit unique in that the office-based services and the technical services for radiation oncology are arranged for through a shared arrangement between Central Health and Ascension. So we each pay a portion of the cost for those outpatient radiation services, and that arrangement is specific to our MAP population. Central Health, just within the past year, expanded access to radiation services to the MAP basic population really for the first time in a systematic way just this year. Originally that was planned to be an effort that we would pursue jointly with Ascension. They declined to participate in that, so Central Health is funding access to those MAP basic patients today. We also added a new provider in this space. Traditionally, Austin Cancer Center was the sole provider of radiation oncology services in the outpatient environment for our patients. That practice has since split into two groups. We have arrangements with both of those groups now, and we're excited that for the first time this year we have a contractual relationship with Texas Oncology. We really used radiation as the first area to build on that partnership. It has made I think now a total of 12 different locations available for our patients across Travis County and the immediate surrounding region. And again, just for a sense of scale, we have approximately 100 patients a year under that prior MAP-only service that were accessing radiation services in our population. So I think the addition of MAP Basic should grow that pretty substantially over the coming year. And I think that's it. I hope that was short as promised. Happy to answer any questions, and obviously we'll have a lot more conversation about this going forward.
All right. Again, 9:39. Manager Massaita.
Mine is going to be very quick. It's 9:39. Thank you, I appreciate it. I look forward to future discussions over this. I'm glad that you're hopefully going to have some dialogue with the MD Anderson coming forward. So I look forward for those conversations. Thank you.
Thank you. Manager Valadez.
My father died. He had non-Hodgkin's lymphoma. My brother died. He had a very aggressive form of leukemia. My sister had a double mastectomy. She's still with us. Cancer runs in the family. And in looking at, just briefly, you know, one of the 6 least survivable cancers is lung cancer. And yet lung cancer is on there. I was just curious as to the selection of the cancers. Why were they selected, you know, as opposed to all the cancers? And at some point in time, we don't have to have this discussion today, but understand that what has the highest likeliest survival rate? You know, what is the most severe, so we can try and dig into that also. Those kinds of issues are important for families, because I don't believe my family is any different than any other family. But I'm just curious as to the selection of the particular cancers to prioritize.
Great question.
First of all, sorry to hear about your,
That's
your
okay.
family history.
That's okay. I've got Gloria.
The cancer screening that we put up there is just the available methods really to screen. So obviously there are some blood cancers that are much tougher to screen because there's no general marker that for the general population, you know, you screen everybody. So I think if you look at U.S. Preventive Services Task Force or some of the other bodies that just recommend general screening, you know, that's why we focus on that. But obviously every cancer is really important to screen, and then obviously, you know, treat and care for if we can.
I guess what I was asking, I was hoping for a response to how the selection was made for what cancers. You're going by a federal study that was conducted. Okay.
I'm happy to defer to all of the clinicians in the room, but my understanding, Manager Valadez, is these are the primary cancers that have a screening available. There are a lot of other cancers, absolutely, that don't have a routine screening recommended. So that
I appreciate that.
And I think it's left up to individual providers to determine what's appropriate. You know, one of the sources that I think we look to are, you know, the U.S. Preventative Services Task Force that was mentioned. You know, HRSA, that I think was mentioned in the prior presentation, also specifies some of the measure specifications for who qualifies for a particular screening. So we really try to align with those national standards.
Thank you very much. Manager Jones.
Just quickly, why not prostate cancer?
There's actually a recommendation against screening for prostate cancer. Prostate cancer can be very rapidly growing, but the majority of them are actually very slow growing. So it's based on individual patient-provider decision-making and symptomology, and then workup by patients. But they used to do PSAs all the time, and what that showed is that there were many more procedures that were unnecessary than actually the treatments for the cancer, and so there was a recommendation against.
Well, Black men particularly have the highest rates of prostate cancer deaths, so the question is, I understand what the research is saying, but it's been encouraged to have that done, particularly at certain rates, so I was just wondering why not prostate.
And specifically for different races and family histories, that's where the provider-patient relationship comes into play, and different providers would then, you know, proactively screen that patient.
Okay, thank you.
Thank you very much. Thank you, guys. We really appreciate the information. Go ahead, one sentence.
One sentence comment. In light of what Manager Jones has brought up, I'd like to know whether or not you all could maybe consider looking at our equity issues within Travis County and seeing what cancers would best be provided, or what cancer screenings might be best provided to our targeted population. Thank you.
Thank you very much. Appreciate it. Okay, members, I need to bring up Backup item number 2, agenda item number 2, which is receive and take appropriate action on the proposed Central Health fiscal year 2024 budget. I have a copy of the budget resolution as amended will be passed out to you, all right? And I've started a copy where we've signed because I'm losing people as we speak. So if you are not, we voted on all the amendments, and so the amendments are included as we voted on them. If you want to wait to sign before and read it, that's fine with me, but I do need to recognize Manager Zamora for a final motion to pass the budget resolution as amended.
I move that the board adopt the budget resolutions as amended and staff incorporating amendments as appropriate to the structure of the resolution.
I recognize Manager Brinson for a second.
I second.
Any further discussion? Hearing none, all in favor?
Aye.
Aye. No, this is not a roll call. Any opposed? Any abstaining? Motion carries. Okay, I'm gonna, you can sign here. You're leaving, right? Okay, I'm gonna leave this here and you can sign before you leave, all right? If you choose to read it before you sign, we will get you copies to read, okay? All right, agenda item number 6, members, there's no presentation on this item, but the materials are available for your review in the backup for the meeting. Staff are available if there are questions, and the agenda item is receive an update on Capital City Innovation, CCI. We will not be taking up items 7 and 9 because they were covered in the Strategic Planning Committee meeting. Agenda item number 7 is receive an update on the Central Health dashboards associated with service level reporting for fiscal year 2023. And agenda item number 9 is to receive and discuss a briefing regarding Travis County Healthcare District doing business as Central Health versus Ascension, Texas, FKA Seton Healthcare Families, cause number D1GN 2300398. Mr. Giesland, do we have any updates on items 8 or 10?
Not on items 10, but on item 8. Earlier this evening, I received a return draft from the county, and this is for the interlocal agreement under number 8, and we'll review that and get back with the board if there's any substantive changes. Otherwise, we'll execute that document.
Okay.
All right, thank you.
All right. I'm sorry. Item number 8, discuss the updates on a performance review contracted by Travis County, including delegations to the president and CEO to execute necessary agreements between Central Health and Travis County and Mazars USA. Thank you, Mike, for that information. There was no information on agenda item 10. Receive and discuss a briefing regarding Birch et al. V. Travis County Healthcare District, DBA Central Health, and Mike Giesland, cause number D1GN 17005-824 in the 345th District Court of Travis County. Agenda item number 11 is to confirm the next regular board meeting, date, time, and location. Managers, our next Central Health Board meeting is tentatively scheduled for Wednesday, October 25th, 2023 at 4 p.m. At Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment. Manager Jones moves adjournment. Manager Matwani seconds. Any further discussion? Hearing none, all in favor?
Aye.
Any opposed? We are adjourned. Thank you. This is the signing copy? No, that's your copy to read, but this is the formal copy to sign.
Okay.
problem.